Good afternoon, everyone. Welcome to episode 53 of Ken's Counseling Couch. I'm your host, Ken Jennings, I think, or the formerly known as Buzz Kennington. Today, we will be delving into a very controversial topic, considering the conversations I've been engaged in a couple discords this afternoon, and some misattributions of my statements and beliefs, but that's a whole other topic. Anyway, today we're going to be discussing the WPATH, which is also known as the World Professional Association for Transgender Health. They are the people who put together the standards of care. Oh, my mic's off a bit. Hold on, let me make sure nothing. Let me check my settings. Damn it, I hate when this shit happens. Yeah. We have Wi-Fi microwave. Okay, it should be working now. Perfect, there we go. It does work. Apparently, I had left my settings wrong, and I was streaming from my built-in microphone on my laptop, not my expensive fucking setup. So, that'll do it. Note to self, check your audio settings and check your software before logging in and doing what you're supposed to be doing. I also need to make sure my laptop's plugged in at some point too. Anyway, so the WPATH has released Standard of Care version 8. I believe they're effective September 2022, so they just came out this month. I believe they came out within the last couple weeks because the WPATH had their annual meeting symposium shit on the 16th through the 20th. So we're talking like brand fucking new. No one else has really covered this to the extent I'm about to, not that I've seen on YouTube. So what we're going to do is we're going to do a deep dive into different sections of this. I have yet to actually read through this. What we're going to do is do some of the different sections. We're going to go into the sections on adolescents and children, and then we will go into the sections on hormone therapy, surgery and postoperative care, primary care, reproductive health, sexual health, and stuff like that as we go along, depending on how long this takes. Because of this topic and wanting to be able to stay focused and provide something educational, I'm going to make up my drinking later or tomorrow on a stream where we go through different board complaints of people that have been reported to the licensing board for the licensing. And some of them are really funny and really fucked up and really good reasons those people are not therapists anymore. That's more for drinking. This one's more serious, so I do want to stay focused. Read a DM group. Yeah, I know, Twisted. I'm bad about DM. Let me pop in real quick. Say, okay. As far as that second message you sent on the 23rd, I've already taken care of that. And I will deal with the mod thing here later. But for now, let's go ahead and jump into this. I just want to let you know I did just check it. And I will reply to you. I have been, my ADHD's been a little bad recently. I just got my meds refilled recently. So let's share screen. I had to refresh my fucking browser to get the mic to work. So sorry for the delay. I wasn't ignoring you, I promise. All right, so here we go. Actually, let me get to the right section first. So, adolescent section. So, let me see if I can skim some of this stuff and make sure. All right. All right, so let's do this. I'm going to jump in right here. We're going to jump right into this, and I'm going to show you that I'm not ignoring important stuff. The adolescent section starts here. This is historical context. It's got statistics on data and stuff like that. I don't know if you guys care to read that or not. My throat hurts a little bit too. So what we'll do is we will go down to right here. For clarity, this chapter applies to adolescents from the start of puberty until the legal age of majority, which is in most cases 18 years. However, there are developmental elements of this chapter, including the importance of parental caregiver involvement, that are often relevant for the care of transitional aged youth, young adults, and should be considered appropriately. So that's for this chapter in adolescence and why it's important. So understanding the definitions will always be important if we go through this. It's highlighted in bold, so I figured it was important to read them. All right. Let's see. So we'll start reading here. I think this is only a few pages. Oh shit. Hold on. I gotta plug my laptop in. Give me 1 second. Okay, there we go. Also, hi Royal. It's nice to see you. So let's see. All right. Where is? All right, we're going to read this because I think it does cover some important stuff that will matter. If it doesn't, I'll skip it in the next sections. So let me pull out my highlighter because God knows I love highlighting shit. First, I need to go to this section. Here, there, color, start with pink. So pink is awesome. So, cognitive development in adolescence is often characterized by gains in abstract thinking, complex reasoning, and metacognition, i.e., a young person's ability to think about their own feelings in relation to how others perceive them. I'm going to skip the citations for just ease of reading. The ability to reason hypothetical situations enables a young person to conceptualize implications regarding a particular decision. However, adolescence is often associated with increased risk-taking behaviors. I will say that's important. Along with these notable changes, adolescence is often characterized by individuation from parents and the development of increased personal autonomy. There is often a heightened focus on peer relationships, which can be both positive and detrimental. Adolescents often experience a sense of urgency that stems from hypersensitivity to reward, and their sense of timing has been shown to be different from that of older individuals. I hit on this all the time, that kids and adults see things differently as far as time and the different reasons and motivations for them. Oh God, my throat hurts, man. Let's see. Socio-emotional development typically advances during adolescence, although there is a great variability among young people in terms of the level of maturity applied to inter and intrapersonal communication and insight. For TGD adolescents, I think that was defined earlier, I'll clarify that. I think it means, I'll figure it out in a minute. For TGG adolescents making decisions about gender-affirming treatments, decisions that may have lifelong consequences, it is critical to understand how all these aspects of development may impact decision-making for a given young person within their specific cultural context. So then we move into gender identity development in adolescence. And this is probably one of the more important sections that will be necessary to cover. This is why some of the things I've heard about these changes I'm not necessarily on board with, because of the SOCV7 had different restrictions, I think, that help prevent making bad decisions. So as we continue on, our understanding of gender identity development in adolescence is continuing to evolve. Let me turn this off until I have to highlight it. When providing clinical care to gender diverse young people and their families, it is important to know what is and is not known about gender identity during development. When considering treatments, families may have questions regarding the development of their adolescent's gender identity and whether or not their adolescent's declared gender will remain the same over time. For some adolescents, a declared gender identity that differs from the assigned sex at birth comes as no surprise to their parents, caregivers, as their history of gender diverse expression dates back to childhood, which you do see in some children. They will do different things such as cross-dressing or preferring different gendered toys than they're assigned. And for the purposes of this discussion, I'm going to use the language of the document to keep things clear. So assigned sex at birth or assigned gender at birth is what we'll use throughout the document to keep things clear. So basically, when you're born, they say you're a boy, you're a girl. That's what assigned sex at birth is. Different than your gender. We'll dig into that as we need to. For others, the declaration does not happen until the emergence of pubertal changes or even well into adolescence. Historically, social learning and cognitive development research on gender development was conducted primarily with youth who were not gender diverse in identity or expression, and was carried out under the assumption that sex correlated with a specific gender. Therefore, little attention was given to gender identity development. In addition to biological factors influencing gender development, this research demonstrates psychological and social factors also play a role. While there has been less focus on gender identity development in TGG youth, there is ample reason to suppose, apart from biological factors, psychosocial factors are also involved. For some youth, also, if anyone has questions in the chat as we go along, please say what they are. We're not reading all 260 pages. I am jumping the fuck around. Trust me. I could not read this to you and not hero myself. Trust me. And yes, I'm fine. It's a joke. So, for some youth, gender identity development appears fixed and is often expressed from a young age, while for others, there may be a developmental process that contributes to gender identity development over time. Neuroimaging studies, genetic studies, and other hormone studies in intersex individuals demonstrate a biological contribution to the development of gender identity for some individuals whose gender identity does not match their assigned sex at birth. So what this is saying is there is the apparent possibility, and there has been studies showing biological contribution to gender identity. So it's not just psychosocial. Yeah, I'm going to hit the highlight before my voice gets out. That's probably the best way to put it. As families often have questions about this very issue, it is important to note it is not possible to distinguish between those for whom gender identity may be fixed from birth and for those whose gender identity development appears to be a developmental process. So the difference is, being a developmental process, being fixed at birth means you're seeing the appearance of signs of what your child's gender might be from a young age, versus the changes coming on more around pre-puberty, puberty time. Since it is impossible to definitively delineate the contribution of various factors contributing to gender identity development for any given young person, a comprehensive clinical approach is important and necessary. See Statement 3. We're going to get to the statements here in a bit. Future research would shed more light on gender identity development if conducted over long periods of time with diverse cohort groups. Conceptualization of gender identity by shifting from dichotomous, e.g. binary, categorization of male and female, to a dimensional gender spectrum along a continuum, APA 2013, which it's not like it's new, would be necessary. Why is my fucking charger not working? Give me 1 second. I think my charger can. Oh, never mind. It's charging. I'm stupid. Okay. Adolescence may be a critical period for the development of gender identity for gender-diverse young people. Dutch longitudinal clinical follow-up studies of adolescents with childhood gender dysphoria who received puberty suppression, gender-affirming hormones, or both, found that none of the youth in adulthood regretted the decision they had taken in adolescence. So that's from a 1997 and 2014 study. Oh, shit. Oh, God the fuck damn it. Hold on. Nope. Let's go back. Roll the fuck down. There we go. I didn't know that was going to do that. These findings suggest adolescents who were comprehensively assessed and determined emotionally mature enough to make treatment decisions regarding gender-affirming medical care presented with stability of gender identity over the time period when the studies were conducted. That's going to be something my ass is going to go back and look at later. Because I really want to read those studies. We don't have the time to do that today. That's interesting. What do you mean it's not the reason you decided not to go with grad school for psych? I love being in this field. It's a great field. It's more of it's more nuanced sometimes, but I love being in this field. It's a great field. We're extrapolating findings from the longer-term longitudinal Dutch cohort studies to present-day gender-diverse adolescent seeking care. It's critical to consider the societal changes that have occurred over time in relation to TGD people. Given the increasing visibility of TGD identities, it is important to understand how increased awareness may impact gender development in different ways. One trend identified is that more young people are presenting to gender clinics with non-binary identities. I would agree with that. Another phenomenon occurring in clinical practice is the increased number of adolescents seeking care who have not seemingly experienced gender diversity through their childhood years. One researcher attempted to study and describe a specific form of later presenting gender diversity experience. However, the findings of the study must be considered within the context of significant methodological challenges, including 1, the study surveyed parents and not the youth perspective, and 2, recruitment included parents from community settings in which treatment for gender dysphoria are viewed with skepticism and are criticized. However, these findings have not been replicated. For a select subgroup of young people, susceptibility to social influence impacting gender may be an important differential to consider. I would agree with that. And I'm going to highlight that too for later. I think that will be important. However, caution must be taken to avoid assuming these phenomena occur prematurely in an individual adolescent while relying on information from data sets that may have been ascertained with potential sampling bias, which is something you have to consider doing any research. It is important to consider the benefits that social connectedness may have for youth who are linked with supportive people. Given the emerging nature of knowledge regarding adolescent gender identity development, an individualized approach to clinical care is considered both ethical and necessary. As is the case in all areas of medicine, each study has methodological limitations, and conclusions drawn from research cannot and should not be universally applied to all adolescents. I would agree. I think most would agree with that. This is also true when grappling with common parental questions regarding the stability versus instability of a particular young person's gender identity development. While future research will help advance scientific understanding of gender identity development, there may always be some gap. Furthermore, given the ethics of self-determination in care, these gaps should not leave the TGD adolescent without important and necessary care. Okay, so that's kind of something. So I read that section because it talked about it not being just psychosocial. There is biological impact and influences that seem to go into the establishment of gender identity in youth. So this is not to say, before anyone jumps me and fucking tries to clip me, this is not to say I support everything in this document. I've yet to read the document in full. 260 pages. We're reading some of it. All right, so this will be interesting. The research evidence of gender-affirming medical treatment for transgender adolescents. Here we go. Get into the meat, some of the meat and potato stuff. A key challenge in adolescent transgender care is the quality of evidence evaluating the effectiveness of medically necessary gender-affirming medical and surgical treatments, which is the acronym GAMS is how I'll pronounce it. The medically necessary statement in Global Chapter Statement 2.1. Over time. Given the lifelong implications of medical treatment and the young age at which treatments may be started, adolescents, their parents, and caregivers and care providers should be informed about the nature of the evidence base. It seems reasonable that decisions to move forward with medical and surgical treatment should be made carefully. Despite the slowly growing body of evidence supporting the effectiveness of early medical intervention, the number of studies is still low, and there are a few outcome studies that follow youth into adulthood. That would be a strong limitation. Therefore, a systematic review regarding outcomes of treatment in adolescence is not possible. A short narrative review is provided instead. At the time of this chapter's writing, there were several longer-term longitudinal cohort follow-up studies reporting positive results of early, i.e. adolescent, medical treatment. For a significant period of time, many of these studies were conducted through one Dutch clinic, which is in here. I'm going to highlight these. These findings demonstrated the resolution of gender dysphoria is associated with improved psychological functioning and body image satisfaction. Most of these studies followed a pre-post methodological design and compared baseline psychological functioning with the outcomes after the provision of medical gender-affirming treatment. So medical gender treatments would be anything that's not like social, like transitioning socially, where you change name, you change clothing, you change appearance. Medical means puberty blockers, hormones, surgery, those kind of things. So, I would say, Gabe, it's a bit of, actually, let me do that. I would say there's a bit of, I think, lead up, like you said, almost like you saying damage control. Again, I've only read some of the statements, and I read them briefly while I was talking to my wife about something, so I didn't actually interpret them properly. So we're going to read those together, plus I wanted to do a live react to it. Let's see, where'd I go? Different studies evaluated individual aspects or combinations of treatment interventions and included 1, gender-affirming hormones and surgeries, 2, puberty suppression, and 3, puberty suppression affirming hormones and surgeries. This also needs highlighted. The 2014 long-term follow-up study is the only study that followed youth from early adolescence, pre-treatment, mean age of 13.6, to young adulthood, post-treatment, mean age of 20.7. This was the first study to show gender-affirming treatment enabled transgender adolescents to make age-appropriate developmental transitions while living as their affirmed gender with satisfactory objective and subjective outcomes in adulthood. While the study input is small, 55 N55 select and socially supported sample, the results were convincing. Of note, the participants were part of a Dutch clinic known for employing a multidisciplinary approach, including provision of comprehensive ongoing assessment and management of gender dysphoria, and support and emotional well-being. Several more recently published longitudinal studies followed and evaluated participants at different stages of their gender-affirming treatments. In these studies, some participants may have not started gender-affirming medical treatments. Some had been treated with puberty suppression, while others still had started gender-affirming hormones or had even undergone gender-affirming surgery. Again, highlighting. This is shit to read later. I'm going to have so much shit to read after the stream. Given the heterogeneity of treatments and methods, this type of design makes interpreting outcomes more challenging. Nonetheless, when compared with baseline assessments, the data consistently demonstrated improved or stable psychological functioning, body image, and treatment satisfaction varying from 3 months up to 2 years from the initiation of treatment. Basically saying they saw good results. Again, this is going to be, I think, a controversial document, so we'll see. I'm still not sold, depending on what their things are going to be as we get into the later section. Again, this is their rationalization, this is their reasoning, and the things they're using to back up their standards and their statements that we're going to see here in a bit. Cross-sectional studies provide another design for evaluating the effects of gender-affirming treatments. One such study compared psychological functioning in transgender adolescents at baseline and while undergoing puberty suppression with that of cisgender high school peers at 2 different time points. At baseline, the transgender youth demonstrated lower psychological functioning compared with cisgender peers, whereas when undergoing puberty suppression, they demonstrated better functioning than their peers. Okay. Grannis et al. 2021 demonstrated transgender males who started testosterone had lower internalizing mental health symptoms such as depression and anxiety compared with those who had not started testosterone treatment. 4 additional studies followed different outcome designs. In a retrospective chart study, 𝗞𝗖𝗖 reported transgender adolescents with few or no mental health challenges prior to commencing gender-affirming hormones generally did well during the treatment. However, adolescents with more mental health challenges at baseline continued to experience the manifestations of those mental health challenges over the course of gender-affirming medical treatment. Basically, those who were okay prior to starting the treatment, who were mostly okay, maybe had minor to moderate symptoms versus moderate to severe symptoms, did well during treatment, versus those who had more mental health challenges, like the defined functioning. So that would be something you would see normally in different DSM diagnostics, like levels of functioning, like severity can also help define functioning. Functioning is also how well you're doing. So if I'm able to, for example, pay my bills, live my life, do well in my relationship, my functioning in my life and work is okay. But if I'm having impacts on it, my functioning's not so okay. Depending on the situation, it's not necessarily something that has a list of things you can check off. It depends on what you're doing with it. Oh man, I gotta drink more of this tea. Okay, where to leave off? Snyder studied satisfaction with care as an outcome measure and demonstrated transgender adolescents were more satisfied the further they progressed with the treatments they initially started. 𝗖𝗖 compared health care utilization pre and post initiation of gender-affirming pharmaceuticals as indicators of the severity of mental health conditions among 3,754 transgender adolescents. I'm just going to fucking say that. I'm going to keep fucking stumbling over it. It's trans adolescents in a large healthcare data set. Somewhat contrary to the author's hypothesis of improved mental health care use did not significantly change, and psychotropic medication prescriptions increased. That's interesting. I will definitely want to read that one. In a large non-probability sample of transgender identified adults, Qirbhin found those who reported access to gender-affirming hormones in adolescence had lower odds of past year suicidality compared with transgender people accessing gender-affirming hormones in adulthood. Okay, I really want to see the population size on that one. Actually, let me do a different color because I don't fucking think they're the same one. There we go. Writers may consider the possibility an adolescent may regret gender-affirming decisions made during adolescence, and a young person will want to stop treatment and return to living in the birth-assigned gender role in the future. 2 Dutch studies reported low rates of adolescents, 1.9 and 3.5%, choosing to stop puberty suppression. Again, I want to see sample size on them. Again, these studies were conducted in clinics that have a protocol that includes a comprehensive assessment before the gender-affirming medical treatment started. See, this right here is going to be the fucking thing that's going to piss me off, is having this comprehensive assessment. Is unfortunately we have too many people jumping into this shit. Yeah, can't be like, citation please. Yeah, I'm going to read my citations. Don't you fucking worry. There's reasons for an SOC 7. There wasn't no like time limits on when you could, for adults specifically, when you could start taking hormones. You didn't have to be like suffering from dysphoria for 6 months or a year before you could take hormones. It was based on your level. It's again an individual approach. So, but also some providers who may be politically motivated may decide to do things on their own terms. And unfortunately, it has the potential to impact clients. That's the shit that pisses me off. That's the shit that, like, the bathtub hormone shit. Well, this right here, up here, is saying that kids who accessed it in youth whether they got them legally or not, it helped. There's also possible other health consequences that go with it. Not assessing the situation, not assessing the client properly has the potential to cause harm in other ways outside of the gender dysphoria. At present, no clinical cohort studies have reported on profiles of adolescents who regret their initial decision or detransition after irreversible affirming treatment. So that's a key state. That's a huge statement. Recent research indicates there are adolescents who detransition but do not regret initiating treatment as they experience the start of treatment as part of understanding their gender-related care needs. Okay, that actually makes sense. If anyone doesn't get that, let me know, I'll clarify it, but that makes sense to me. However, this may not be the predominant perspective of people who detransition. Again, more citations. Some adolescents may regret the steps they have taken. Oh my God, so many citations to read. Therefore, it is important to present the full range of possible outcomes when assisting transgender adolescents. Providers may discuss this topic in a collaborative and trusting manner, i.e., as a potential future experience in consideration, with adolescents and their parents, caregivers, before gender-affirming medical treatments are started. Also, providers should be prepared to support adolescents who detransition. Yeah, I bet that providers who push it maybe don't like that. In an internet convenience sample survey of 237 self-identified detransitioners with a mean age of 25.02 years, which consisted of over 90% of birth assigned female. Holy shit. That is huge. I'm going to go ahead and highlight this whole section now. Being 90%, it's self-identified, but 90%. 25% had medically transitioned before age 18, and 14% detransitioned before age 18. Oh my God. That's actually a huge number. Say, given the... I'm going to go into that later. Someone remind me of that in a little bit, about this section. I'll go into some thoughts on that later. Although an internet convenience sample is subject to selection of respondents, the study suggests detransitioning may occur in young transgender adolescents, and healthcare professionals should be aware of this. Many of them expressed difficulty finding help during their detransition process and reported their detransition was an isolating experience during which they did not receive either sufficient or appropriate support. See, that's actually sad, because even if someone makes a bad decision, and people make bad decisions all the time, why do you think people come to fucking therapy? That they're not getting the support they need in the process. You have someone who you may detransition female strap. Okay, thank you, Mike. People could be supported in that. If they want to detransition, let them detransition. Jeez, it shouldn't be that big of a deal. Also, I forgot to turn on the slide in the background. Thank you. Thank you, Self, for reminding me to do that. All right. To conclude, although the existing samples reported on relatively small groups of youth, e.g. N 22 to 101 per study, and the time of the follow-up varied across studies 6 months to 7 years, this emerging evidence base indicates a general improvement in the lives of transgender adolescents who, following careful assessment, receive medically necessary gender-affirming medical treatment. Further, rates of reported regret during the study monitoring period were low. Taken as a whole, the data shows early medical intervention is part of a broader combined assessment and treatment approach focused on gender dysphoria and general well-being, can be effective and helpful for many transgender adolescents seeking this treatment. All right. So, someone... Honestly, Shaftesbury, I would say yes. Honestly, 100%. I believe we're kind of there. I believe we have providers, and I don't want to say that any provider is ever malicious in their intent. I don't like to say that. Maybe their enthusiasm and their investment in their clients overtakes their professional judgment sometimes, and that they're wanting to help, but sometimes helping isn't always the way we think it is. I've had times where the help I've given, I've questioned my own accent, my own thoughts and my own actions in counseling. Not that I've done anything improper, but whether or not it was the right decision. Thankfully, they turn out to be right. But sometimes you push back, and we push back hard. And it's for a reason. And I've had clients thank me after the fact. Like, I really needed you to push me back on that. or, I needed you to question me on that. I tell all my clients, as long as you can justify to me with good evidence your decision making, I'll support it. But you have to be able to do it without using cognitive distortions, without thinking errors and all that shit. As long as you do that, I'll back you up 100%. So I think we have, unfortunately, providers who don't consider the alternative, and that they hear someone come in the door to go, okay, that you're this, okay, cool, let's do it and start the treatment. Versus taking an approach of, hey, you've got this going on, why don't we try doing XYZ first? Why don't we try this? Or help me understand why you feel this way. Give me enough detail. Back up your feelings. Someone asked me to back up my feelings on it. I can go back many years. Many years. I can go back to like age 4 or 5 and back it up with evidence. And then the years following, right? That's how I can say comfortably XYZ. Someone, and again, you have different types of presentations. But so we're getting into the statement of recommendations now for the adolescent section. So let me zoom in a bit more on this 80. Let's see if I can go to 190. I can, look at that. All right. So these are the statement of recommendations. 6.1. I'm not going to do all of the numbers. We recommend healthcare professionals working with gender diverse adolescents, A, are licensed by the statutory body, hold a postgraduate degree or its equivalent in a clinical field to this role granted by a nationally accredited institution. Okay, duh. Receive theoretical and evidence-based training and develop expertise in general child, adolescent, and family mental health across the developmental spectrum. This is why I always tell you guys, knowing child development is a huge piece of doing good therapy. Because it's important when you work with kids. C, receive training and have expertise in gender identity development, gender diversity in children and adolescents, have the ability to assess capacity to assent, consent, and possess general knowledge of gender diversity across the lifespan. D, receive training and development expertise in autism spectrum disorders and other neurodevelopmental presentations, or collaborate with a developmental disability expert when working with autistic, neurodivergent, gender diverse adolescents. Basically, if that's someone that's coming to you and you're not good at it, you're good at it. Or get someone that's good at it. Continue engaging in professional development. Okay, that's all shit we would expect. 6.2, we recommend healthcare professionals working with gender diverse adolescents facilitate the exploration and expression of gender openly and respectfully so that no particular identity is favored. We recommend healthcare professionals working with gender diverse adolescents undertake a comprehensive biopsychosocial assessment of adolescents who present with gender identity related concerns and seek medical, surgical, transition related care, and that this be accomplished in a collaborative and supportive manner. Okay, none of that's controversial to me at this point. We recommend healthcare professionals work with families, schools, and other relevant settings to promote acceptance of gender diverse expression of behaviors and identities of the adolescent. Okay, we recommend against offering reparative and conversion therapy aimed at trying to change a person's gender and live gender expression to become more congruent with the sex assigned at birth. Basically recommending against conversion therapy because evidence has shown that that's dangerous. We suggest healthcare professionals provide transgender and gender diverse adolescents with health education on chest binding and genital pecking, including a review of the benefits and risks. We recommend providers consider prescribing menstrual suppression agents for adolescents experiencing gender incongruence who may not desire testosterone therapy, but who desire but not have yet begun testosterone therapy, or in conjunction with testosterone therapy for breakthrough bleeding. We recommend healthcare professionals maintain an ongoing relationship with a gender diverse and transgender adolescent and any relevant caregivers to support the adolescent in their decision making throughout the duration of puberty suppression treatment, hormonal treatment, and gender related surgery until the transition is made to adult care. Point 9, we recommend healthcare professionals involve relevant disciplines, including mental health and medical professionals, to reach a decision about whether puberty suppression, hormone initiation, or gender-related surgery for gender diverse and transgender adolescents are appropriate and remain indicated throughout the course of treatment until the transition is made to adult care. We recommend healthcare professionals working with transgender and gender diverse adolescents requesting a gender-affirming medical or surgical treatment inform them prior to initiation of treatment of the reproductive effects, including the potential loss of fertility and available options to preserve fertility within the context of the youth stages of pubertal development. We recommend, when gender-affirming medical or surgical treatments are indicated for adolescents, healthcare professionals working with transgender and gender-diverse adolescents involve parents and guardians in the assessment and treatment process, unless their involvement is determined to be harmful to the adolescent or not feasible. The following recommendations are made regarding the requirements for gender-affirming medical and surgical treatment. All of them must be met. All right, so now we're getting into some interesting stuff. My conversion therapy would be, in the context of this, conversion therapy would be trying to say, I identify as a female, even though my assigned sex at birth is male. Conversion therapy in that context would be, you're not a woman, you're a man. There's no way you're a woman, you have to be a man. Just like with gays, conversion therapy for gays was being gay is bad, and they do things that, some really fucked up things that can detransition you, like giving you anemics to make you throw up while watching gay porn, shit like that to make you like sick at the sight of it. That's just one example. Electroshock therapy, stuff like that, to try and make you averse to the homosexual act. There's a lot of reasons that conversion therapy is no longer supported, and it's not just a political thing. Jasper says, if I was a young gay tutor, liked to knit and play with dolls, and due to a bad home life, I never felt right. Would that have been counted as gender diverse, or what would the criteria be? Well, would you identify yourself as gender diverse? Would you identify as anything other than your identifying as anything other than your assigned birth or assigned sex at birth? So if you're born male, even though you say young gay kid, did you identify as anything other than a gay male? Did you identify as a female? Did you identify as non-binary? Did you identify as anything else? Conversion therapy is super unethical. There's a reason why it's not done. And it wasn't always done by therapists. It was a lot of religious organizations were doing that stuff. And so falls outside some of the bounds of who does the care and stuff like that. So there's a reason it's not done anymore, or it's highly recommended again. Okay, so Chef Ray says, how would I know what to identify as other than Tyler? Well, did you feel as though you've met you? So the way I would ask the question would be, do you feel as though you, even though you did those things, knitted, played with dolls, did you feel like you were still a man? Did you identify as a male? Do you feel or identify as more feminine? Do you ever wish you were a woman? Do you ever wish you were a girl? Do you ever have more identification with being a girl versus being a guy? There's a bunch of things that can go into that. That's the shit that's like a couple therapy sessions long, is if you're trying to explore that. And as a child, it's not always something you can know. Like earlier in this thing was saying, is you can have presented with some of this stuff from young ages, or sometimes it doesn't show up until puberty or pre-puberty, or later in adolescence. Say, Adam says, I identify as a cat, or I identify as a Ken. Yes, Ken is a gender. All right, so these are the recommendations for medical and surgical treatment, and all of them must be met. Again, we're in the adolescent section, so all of these have to be met for any of the medical care to be done. So let's do this, clarify this, because this will probably be part of the video someone requested I make a short video later to go through some of it. So 6.12. We recommend healthcare professionals assessing transgender and gender diverse adolescents only recommend gender affirming medical or surgical treatments requested by a patient when A, the adolescent meets the diagnostic criteria of gender incongruence as per the ICD-11 in situations where a diagnosis is necessary to access healthcare. In countries that have not implemented the latest ICD, other taxonomies may be used, although efforts should be undertaken to utilize the latest ICD as soon as practicable. B, the experience of gender diversity incongruence is marked and sustained over time. C, The adolescent demonstrates the emotional and cognitive maturity required to provide informed consent, assent for the treatment. D. The adolescent's mental health concerns, if any, that may interfere with diagnostic clarity, capacity to consent, and gender-affirming medical treatments have been addressed. I think that's an actual good thing to add in there. E. The adolescent has been informed of the reproductive effects, including the potential loss of fertility and the available options to preserve fertility, and these have been discussed in the context of the adolescent stage of pubertal development. F. The adolescent has reached Tanner stage 2 of puberty for pubertal suppression to be initiated. G. The adolescent had at least 12 months of gender-affirming hormone therapy or longer, if required, to achieve the desired surgical result for gender-affirming procedures, including breast augmentation, orchiectomy, which is removal of the testes, vaginoplasty, which is the creation of a neovagina, hysterectomy, which is removal of uterus, phalloplasty, which is the creation of a neopenis, amnionoplasty, which I don't remember what that one is. Someone pull that one up for me because I don't remember. And facial surgery is part of gender-affirming treatment unless hormone therapy is either not desired or is medically contraindicated. So that means that maybe there's a health issue that would prevent you from being able to access the treatment. Taking estrogen or testosterone supplements could say you have an increased risk of heart disease or heart failure because of that. Yes, that's actually a thing. I'm not making shit up. And for those who are unfamiliar with what Tanner stage 2 is, Tanner stage 2 is, let me see if I can pull it up. I'm trying to find one that's not going to get me make my stream adults fucking censored. Is this one? All right. Okay, here we go. It's just a chart, so I'll read it for you. So for Tanner stage 2 for females will be breast bud under the areola and areola enlargement. You'll also see sparse hair along the labia with body growth around 2.8 to 3.2 inches per year. You'll also see clitoral enlargement, labia pigmentation, and growth of the uterus during Tanner stage 2. For males, Tanner stage 2 would be testes measuring 2.5 to 3.2 centimeters and thinning and reddening of the scrotum, sparse hair at the base of the penis, 2 to 2.5 inches per year of height growth, and a decreases in body fat can also occur. So that's that. My personal opinions haven't gotten there yet. I'm not. Okay, thank you for that. I thought it was called something. That's weird. I thought that was phalloplasty. I guess it's a different place. Anyway. Oh, okay, that makes sense. Oh, I see what they're doing with that. I understand that. No, we're actually at this stage, we're talking about adolescence. So we're talking from basically, this is what's saying here is for this. Okay, so let me basically do this. Let me summarize this real quick. This is for gender affirming medical and surgical treatment. Medical treatment being puberty blockers, hormone surgeries of any kind. All these criteria here had to have been met, which we just read, right? One of the criteria is the youth has reached Tanner stage 2, which you usually see around, I think, what? Age 10, give or take? Age 12? Hold on, let me see. Usually you reach Tanner stage 2 anywhere between 8 to 15, give or take. So basically you've hit the start of puberty. Tanner stage 1 is basically before puberty. Tanner stage 2 is where you start to see indications of puberty, like breast buds or beginning of pubic hair growth and stuff like that. let me go ahead and give you a bit of a tip. I don't like this. At this point, I'm not comfortable with this. Because standard stage 2, as I just went over, is the age anywhere between 8 to 15, depending on when you hit puberty. Puberty can start earlier or later for people. Okay. But the access of care, to me, I think this has the potential for more harm than good. Is my personal opinion of this right now. Professionally, I have to deal with this differently. Personal opinion, how I would deal with this professionally is going to be complex if I run into this anytime soon. I hope to God I don't. But, so that's where we sit on that. So this actually, let me fucking highlight it because I'm going to need it later. These requirements for surgery treatment and medical care, I don't like at all. There are some actually good things in here that I would be okay with if we were to shift age or puberty levels higher, maybe. And I'm never okay with surgery prior to age 18. I'm never okay with surgery prior to age 18. I don't think it's required. Especially when you're talking going full gender reassignment surgery. Going what they call, for lack of a better term, bottom, the term in the side, the community, bottom surgery being removing the vagina, adding a penis, removing the penis, adding a vagina, basically. Prior to age 18, I don't think you should make that decision. The lowest I could ever, and it will require like really, really strict things, and because again, there's no time. The only time limit. Let me undo the highlight for a minute. The only time limit in here is that prior to surgery, that the adolescent has been on hormones for at least 12 months. Prior to that, outside of that, so effectively, if you're on hormones 13 for a month, for 12 months, you now meet the requirements, assuming that you meet the other requirements here. You meet the ICD-11 diagnosis if you need the diagnosis to access healthcare, because you don't necessarily need it. Your incongruence is sustained over time, and over time isn't defined. This is sort of done for good and bad reasons, and the last one too. Putting time limits on it can be good or bad. You have to show that it's sustained. Sustained over time for some people could be 6 years. Some people it could be 6 months. When do you actually draw the cutoff? How do you know a person has met that requirement? It's a rhetorical question. I don't know the answer to it, but I think it's important to think about. But demonstrating the emotional and cognitive maturity required to provide informed consent is sensitive treatment. The question is how does this work with the child can consent, but now with the parent not consenting? And someone was showing me videos earlier. Someone in the Discord had said, linked to a video of one of the WPATH board members who were part of the Standards of Care board talking about the utilization of CPS for enforcement of treatment of social transition on youth. And I think that's a bad thing. Is basically saying that CPS can be used to help basically enforce the social transition of a youth. Again, how do they remove a vagina foam spray? That's probably another stream, or that would probably need to be a local thing, because I cannot show some of that on stream. But basically, you remove for one of the methods to create the neopenis, they will take a flap of skin off of your arm, elbow region, and use that to construct the shaft of a penis after removing your internal organs, so your ovaries, uterus, and vagina. They can reuse some of the tissue in different ways. The opposite way I know more about, from male to female. Female to male stuff is not as advanced. It's male to female surgery. So there's that. Now I want to go through, because basically these statements here, I read the summary of the statement. Now we're at the section where we have the statements, and then there's citations to the justification for it. So I want to find questions on, hold on. No, keep going. All right, I'm going to read 6.5 because this is talking about the conversion therapy thing, which someone mentioned in the chat. So we'll talk about this real quick and we'll continue forward. Recommend, let me zoom in this again so you guys can see it a bit better. There we go. We recommend against offering reparative and conversion therapy aimed at trying to change a person's gender. And so that's the statement, right? That was the statement. Some healthcare providers, secular or religious organizations, and rejecting families may undertake efforts to thwart an adolescent's expression of gender diversity or assertion of a gender identity other than the expression of behavior that conforms to the sex assigned at birth. Such efforts at blocking reversible social expression or transition may include choosing not to use the youth's identified name and pronouns or restricting self-expression in clothing and hairstyle. These disaffirming behaviors typically aim to reinforce views that a young person's gender identity or expression must match the gender associated with the sex assigned at birth or expectations based on the sex assigned at birth. Activities and approaches, sometimes referred to as treatments, aimed at trying to change a person's gender identity or expression, become more congruent with the sex assigned at birth have been attempted, but these approaches have not resulted in changes in gender identity. So I'm going to highlight that. If I missed it. We recommend against such efforts because they have been found to be ineffective and are associated with increases in mental illness and poor psychological functioning. Yeah, there's a reason conversion therapy has been kind of pushed aside for many years at this point. Much of the research evaluating conversion therapy and reparative therapy has investigated the impact of efforts to change gender expression, masculinity, or femininity, and its conflated sexual orientation with gender identity. That too. Some of these efforts have targeted both gender identity and expression. Conversion or reparative therapy has been linked to increased anxiety, depression, suicidal ideation and suicide attempts, and healthcare avoidance. Also, I'm going to have so many fucking citations to read. Although some of the studies have been criticized for their methodologies and conclusions, which I will highlight that one, this should not detract from the importance of emphasizing efforts undertaken a priori to change a person's identity are clinically and ethically unsound. I can mostly agree with that. We recommend against any type of conversion or attempt to change a person's gender identity because one, both secular and religious-based efforts to change gender identity expression have been associated with negative psychological functioning that endures into adulthood. And two, the larger ethical reasons exist that should underscore respect for gender diverse identities. It's important to note potential factors driving a person's gender-related experience and report of gender incongruence when carried out in the context of supporting an adolescent with self-discovery is not considered reparative therapy as long as there is no a priori goal to change or promote one particular gender identity or expression. To ensure these explorations are therapeutic, we recommend employing affirmative consideration and supportive tone in discussing what steps have been tried, considered, and planned for a youth's gender expression. These discussion topics may include what felt helpful or affirming, what felt unhelpful or distressing, and why. We recommend employing affirmative response to these steps and discuss statements such as those identified in SOC 8 Statement 6.4. Okay, so there's the whole reason for yeah, conversion therapy has been defined as overbroad sometimes. I'll give you that one. But for the true conversion therapy, it has been shown to be harmful. And that's not just relating to trans issues too. That's relating to homosexuality as well. Let's see here. Just trying to skim some of this so we don't have to necessarily read it. Hold on one second. See here, 610. See, this is one of the things I think is important. Is the issue regarding fertility. I have yet to get 100 subscribers on Rumble. So those who are wanting me to stream on Rumble, I need 100 subscribers. So make sure you share my Rumble link, get me to 100 Rumble subscribers, and I will stream on Rumble. I was going to stream on Odyssey, but I was running behind on I was feeling sick last night. I was slept in a little bit, so I wasn't able to get my stream up on time today. Hence the few hour delay in my normal stream time. And then I was going to stream about something completely different, and then I found out about this because people were criticizing me about my takes on shit and calling me a map or whatever. I don't care because I'm not one. I'm here to try and present the actual evidence. Yeah, hold on. I should have Rumble now. My Rumble not. Hold on. Let me sign in. I should have a Rumble page. Am I not? Where's my... I don't think I'm at 100 subscribers yet. On Rumble. My content. Yeah, I've only got 30 guys right now. If you want me to stream on Rumble, I'm going to need you guys to go over to Rumble and sub. Make sure you subscribe to me on Rumble. That way I can also stream on Rumble and alternative platforms so I don't get fucking copyright struck because it's stupid shit. But yeah, make sure you guys subscribe to me on Rumble. I just skimmed through some of this so I don't have to read through it. Plus, I'm losing my voice. All right, we're getting into the surgery stuff. Thank you, Mike. Thank you, whoever subscribed to me on Rumble. Once I get to 100, I will stream on Rumble. I will try to start streaming on Odyssey. It's a pain in the ass sometimes because you have to set up the streams, each one separately. There's no individual way to set them all up at once with the descriptions and titles and shit. Let me skim through down to some of these. Here we go. 6.12b. The experience of gender diversity incongruence is marked and sustained over time. Identity exploration consideration are experienced by many adolescents. Identity exploration during adolescence may include a process of self-discovery around gender and gender identity. Little is known about how processes that underlie consolidation of gender identity during adolescence may impact a young person's experiencing needs over time. Therefore, the level of reversibility of a gender-affirming medical intervention should be considered, along with the sustained duration of a young person's experience of gender incongruence when initiating treatment. Given potential shifts in gender-related experiences and needs during adolescence, it is important to establish the young person has experienced several years of persistent gender diversity incongruence prior to initiating less reversible treatments such as gender-affirming hormones or surgeries. So I would say it's important that they put that in there. At least that's in the description part, or in the detailed part. I was worried it wasn't going to be. Puberty suppression treatment, which provides more time for younger adolescents to engage in decision-making capacities, also raises important considerations. So 612F and Chapter 12, which we'll get to in a bit. Suggesting the importance of a sustained experience of gender incongruence diversity prior to initiation. However, in this age group of younger adolescents, several years is not always practical nor necessary given the premise of the treatment is a means to buy time while avoiding distress from irreversible pubertal changes. For youth who have experienced a shorter duration of gender incongruence, social transition-related and/or medical supports such as menstrual suppression or androgen blocking may also provide some relief as well as furnishing additional information to the clinical team regarding a young person's broad gender care need. Establishing evidence of persistent gender diversity incongruence typically requires careful assessment with the young person over time. When possible and when appropriate, the assessment and discernment process should include the parents and caregivers. Evidence demonstrating gender diversity and congruence sustained over time can be provided via history obtained directly from the adolescent and parents, caregivers when this information is not documented in the medical records. The research literature on continuity versus discontinuity of gender-affirming medical care needs requests is complex and somewhat difficult to interpret. A series of studies conducted over the last several decades, including some with methodological challenges, suggest the experience of gender incongruence is not consistent for all children as they progress into adolescence. For example, a subset of youth who experience gender incongruence or who socially transition prior to puberty over time can show a rejection in or even full discontinuation of gender incongruence. That's actually interesting. Highlighting that. However, there has been less research focused on rates of continuity and discontinuity of gender incongruence and gender-related needs in pubertal and adolescent populations. The data available regarding broad, unselected, gender-referred pubertal adolescent cohorts from the Amsterdam Transgender Clinic suggests that, following extended assessments over time, a subset of adolescents with gender incongruence presenting for gender care elect not to pursue gender-affirming medical care. More to check out later. Oh my God, so much citation. Oh my God, yeah. Importantly, findings from studies of gender incongruent and pubertal adolescent cohorts, in which participants who have undergone comprehensive gender evaluation over time have shown persistent gender incongruence and gender-related needs and have received referrals for medical gender care, suggest low levels of regret regarding gender-related medical decisions. Critically, these findings of low regret can only currently be applied to youth who have demonstrated sustained gender and gender-related needs over time as established through a comprehensive and iterative assessment. Oh God, I hate fucking paper language sometimes. It's so fucking complex. Oh, I agree. That's also, so here's the thing with that, is it also, you'll see that with the way that a lot of transgender issues are handled for both adults and children and adolescents, is that I've known people who still worked from like the DSM-4 or DSM-4 TR when DSM-5 was out. Like they continue to diagnose and do things based off of that, and I felt that was inappropriate. So I know that's different because the thing is, gender identity and something like that are two separate issues. Because, and I'm still trying to get a good response to this, because the common statement of, and it's just something that, and Tracy, if you're listening, I'd like your input on this, is I'm trying to get the right way to phrase it regarding people who say that transgender or gender dysphoria is nothing but a delusion, but it's actually a different thing, and it's hard for me to put it into words how it's separate from a delusion. I'm not saying it's ideal. I'm not saying we should do this. I have issue with starting things so young. The only thing I could be really comfortable with is, again, with research showing the long-term side effects are minimal or can be mitigated, would be puberty blockers to allow the chance to determine what you would rather do. Social transition is fine because you can detransition socially with no problem. The moment you start doing medical transition, the ability to detransition or to change your mind, if I want to go to work wearing a dress today, I can go to work wearing a dress today. If I don't want to do that anymore, I can just stop wearing a dress. If I start taking hormones and I start growing breasts, you can't really just undo the breast growth. It's kind of something that's not easy to do. It just doesn't go away. It's not like they go whoop, right back in. That's not how it works. So, all right. Let's see. My issue with it is, you also hit a line too, I think, and it's an interesting point of discussion, and I don't necessarily know if there's a right answer, is the consent for treatment with the child versus the parent. Normally, children don't have the ability to consent for many things. Usually, the parents are perfect consenting, or we have this kind of separate class as it regards to this legal subset. Like, so how this works in law and how this will work in practice is going to be complex. My concern is we're going to see this used in ways that hurts people. And I'm not trying to be Debbie Downer and make a slippery slope fallacy argument. So this section here is from 6.12c on being able to determine whether the person can consent. The following questions may be useful to consider in assessing a young person's emotional and cognitive readiness to assent or consent to a specific gender-affirming treatment. Can the young person think carefully into the future and consider the implications of partially or fully irreversible intervention? Does the young person have sufficient self-reflective capacity to consider the possibility that gender-related needs and priorities can develop over time, and gender-related priorities at certain points in time might change? Has the young person to some extent thought through the implications of what they might do if their priorities around gender do change in the future? Is the young person able to understand and manage the day-to-day, short and long-term aspects of a specific medical treatment, such as medication adherence, administration, and necessary medical follow-up? I will say that I've had two 12-year-olds, give or take. They were somewhere around 12 years old. Both of them around the same age, as clients at the same time, in my office back to back, one after the other, who you could clearly tell, one, extremely intelligent, aged way beyond their years cognitively. You would think this person not yet hitting teenage years, you would think was an adult cognitively. They could think, they had metacognition ability. They could think through all these things. Where the other kid, I don't think they could do that. I don't think they had that metacognition. They were not there. They had yet to make that cognitive developmental step. So if those two people came in, they were my patients. Now I was given the recommendation. I would say, one, this person could probably make person A could probably make the determination to consent or assent to treatment, because they can think through and they have the capability and capacity, because they're cognitively advanced enough and intelligent enough to understand what they're getting into. Versus person B, I don't think the kid was ready to do that. I don't think they could meet much of that. I don't think they could think that far into the future. Think of the ramifications of losing fertility, losing other things. I think that's a big deal. So when you lose that, that's a huge change. When you can't do that, then that person's not ready to consent. So again, all this is going to come down to implementation. So Tim, stop talking about my lady underwear. That's not nice. Assessment of emotional and cognitive maturity has been accomplished over time as the care team continues to engage. And for unique situations in which, for unique situations in which an adolescent might be consenting for their own treatment without parental permission, extra care must be taken to support the adolescent's informed decision making. This will typically require greater levels of engagement and collaboration between the healthcare providers working with the adolescent to provide the young person appropriate cognitive and emotional support, consider options, weigh benefits and potential challenges/costs, and develop a plan for any needed and potentially ongoing supports associated with treatment. Let's see here. Okay, so this is talking about the other mental health issues impacting the treatment of and moving forward with the medical treatment, right? Mental health difficulties may challenge the assessment and treatment of gender-related needs of trans adolescents in various ways. First, when a trans adolescent is experiencing acute suicidality, self-harm, eating disorders, and mental health crises that threaten physical health, safety must be prioritized, as always. According to the local context and existing guidelines, appropriate care should seek to mitigate the threat or crisis so there is sufficient time and stabilization for thoughtful gender-related assessment and decision-making. For example, an actively suicidal adolescent may not be emotionally able to make an informed decision regarding gender-affirming medical or surgical treatment. If indicated, safety-related intervention should not preclude starting gender-affirming care. Second, mental health care can also complicate the assessment of gender development and gender identity-related needs. For example, it is critical to differentiate gender incongruence from specific mental health presentations, such as obsessions and compulsions, special interest in autism, rigid thinking, broader identity problems, parent-child interaction difficulties, severe developmental anxieties, for example, fear of growing up, and pubertal changes unrelated to gender identity, trauma and/or psychotic thoughts. Mental health challenges that interfere with the clarity of identity development and gender-related decision-making should be prioritized and addressed. So basically, those have to take priority to the gender identity because those have other factors at play. If those aren't taken care of first, then it impacts the ability to consent to that kind of treatment and to have the ability to work through that kind of treatment. Third, decision-making regarding gender-affirming medical treatments that have lifelong consequences require thoughtful, future-oriented thinking by the adolescents with support from the parents and caregivers as indicated. To be able to make such an informed decision, an adolescent should be able to understand the issue, express their choice, appreciate, and give careful thought regarding the wish for medical affirming treatment. Neurodevelopmental differences such as autistic features or autism spectrum disorder may challenge the assessment and decision-making process. Neurodivergent youth may require extra support structure, psychoeducation, and time built into the assessment process. Other mental health presentations that involve reduced communication and self-advocacy, difficulty engaging in assessment, memory and concentration difficulties, hopelessness, and difficulty engaging in future-oriented thinking may complicate assessment and decision-making. In such cases, extended time is often necessary before any decisions regarding medical affirming treatments can be made. Finally, while addressing mental health concerns is important during the course of medical treatment, it does not mean all mental health challenges can or should be resolved completely. However, it is important any mental health concerns are addressed sufficiently so that gender-affirming medical treatment can be provided optimally, such as medication adherence, attending follow-up medical appointments, self-care, and particularly during post-operative care. And then, so 612E was talking about the loss of fertility and understanding it. So 612F, adolescents reach gender stage 2 for pubertal suppression to be initiated. Well, let's read this one. Oh man, we might have to end this once we finish this section and do the other part another day. I'm having a real hard time speaking. Okay, so the onset of puberty is a pivotal point for many gender diverse youth. For some, it creates an intensification of their gender incongruence, and for others, pubertal onset may lead to gender fluidity or even attenuation of a previously affirmed gender identity. The use of puberty blocking medications such as GnRH analogs is not recommended until children have achieved a minimum of gender stage 2 of puberty because of the experience of physical puberty may be critical for further gender identity development for some trans adolescents. Therefore, puberty blockers should not be implemented in pre-pubertal gender diverse youth. So even here, with even the issues I take with this, at least this document is saying that no one should be giving puberty suppression hormones or medical puberty suppressing medication or hormone therapy to anyone who is not Tanner stage 2. So that has not at least started puberty. So any of those kids that are allegedly between like 5 and 12 that are taking these medications who have not started puberty, that's no longer, not that it was okay, it's still not okay. The SOC 8 is at least saying that's not okay. I can at least back that up with the SOC. It's not okay. There's a reason for that. As it just said, the onset of puberty is important to understanding the gender identity, right? For some youth, GnRH agonists may be appropriate in late stages or in post-pubertal period, Tanner stage 4 or 5, and this should be highly individualized. Let's see Chapter 12 on hormone therapy for a more comprehensive view of GnRH agonists. Variations in the timing of pubertal onset is due to multiple factors, sex assigned at birth, genetic nutrition. Tanner staging refers to the 5 stages of pubertal development ranging from prepubertal stage 1 to postpubertal and adult sexual maturity, Tanner stage 5. For assigned females at birth, pubertal onset, gonad arc is defined by the occurrence of breast budding. And for birth assigned males, the achievement of a testicular volume of greater than or equal to 4 milliliters. An experienced medical provider should be relied on to differentiate the onset of puberty from physical changes such as pubic hair and epicrene body odor due to sex steroid produced by the adrenal gland, adrenarche, as adrenarche does not warrant the use of puberty blocking medication. Educating parents and families about the differences between adrenarche and gonad arc helps families understand the timing during which shared decision making about gender-affirming medical care therapy should be undertaken with their multidisciplinary team. Oh my god, I fucking hate when they word shit like this. The importance of addressing other risks and benefits of pubertal suppression, both hypothetical and actual, cannot be overstated. Evidence supports the existence of surgical implications for transgender girls who proceed with pubertal suppression. More shit to read up on. Longitudinal data exists to demonstrate improvement in romantic and sexual satisfaction for adolescents receiving puberty suppression, hormone treatment, and surgery. Definitely want to read that one. A study on surgical outcomes of laparoscopic intestinal vaginoplasty performed because of limited genital tissue after the use of puberty blockers in transgender women revealed that the majority experienced orgasm after surgery, 84%, although a specific correlation between sexual pleasure outcomes and the timing of pubertal suppression initiation was not discussed in the study, nor does the study apply to those who will prefer a different surgical procedure. Basically, this procedure takes a section of the sigmoid colon, I believe, and uses it to create the neovagina. It's actually a really neat procedure from a medical standpoint. This underscores the importance of engaging in discussions with families about the future unknowns related to surgical and sexual health outcomes. All right. Consideration of ages for gender-affirming medical and surgical treatment for adolescents. Age has a strong, albeit imperfect, correlation with cognitive and psychosocial development and may be a useful objective marker for determining the potential timing of intervention. Oh my god, I can't fucking speak today. Higher, i.e. more advanced ages may be required for treatments with greater irreversibility, complexity, or both. This approach allows for continued cognitive and emotional maturation that may be required for the adolescent to fully consider and consent to increasingly complex treatment. As I was saying, two clients, one very far advanced cognitively, the other not so much. Not that the second person was any of their fault, they just hadn't reached that stage of development yet. So while age, what this is saying, I think so far, is while age is a decent, like you could say a hard cutoff of 16, you could have a 16-year-old who's not cognitively developed yet because they're a late bloomer. Right? They haven't really gotten into puberty yet. Versus you could have, theoretically, a 13-year-old who is more advanced and developed than a 16-year-old cognitively, able to make the decision-making versus, what am I trying to say? He's able to make the decisions versus the other one because they have the cognitive ability to do things like metacognition. So those are important things when doing shit like this. Not that I support hormone and surgical interventions in children and adolescents. I'm saying is if you're considering it, having a cognition ability, what their justification is that, I think is what they're trying to say, is that age isn't the best cutoff method. And I think that's what they're trying to justify here. A growing body of evidence indicates providing gender-affirming treatment for gender-diverse youth who meet criteria leads to positive outcome. However, there is limited data on optimal timing of gender-affirming interventions, as well as the long-term physical, psychological, and neurodevelopmental outcomes in youth. Currently, the only existing longitudinal studies evaluating gender-diverse youth and adult outcomes are based on a specific model, i.e. the Dutch approach, and that involved a comprehensive initial assessment with follow-up. In this approach, pubertal suppression was considered at age 12, GAHT at age 16, and the surgical interventions after age 18 with exceptions in some cases. It is not clear if deviations from this approach could lead to the same or different outcomes. Longitudinal studies are currently underway to better define outcomes as well as the safety and efficacy of gender-affirming treatment in youth. Really want to read that. While the long-term effects of gender-affirming treatments initiated in adolescence are not fully known, the potential negative health consequences of delaying treatment should also be considered. I also want to read that. Again, I'm not reading those on stream. Not today, sorry. I could barely finish this. I'm struggling to not lose my voice. As the evidence base regarding outcomes of gender-affirming interventions in youth continues to grow, recommendations on the timing and readiness for these interventions may be outdated. Previous guidelines regarding gender-affirming treatment of adolescents recommended partially reversible GAHT could be initiated at approximately 16 years of age. More recent guidelines suggest there may be compelling reasons to initiate GAHT prior to age 16, although there are limited studies on youth who have initiated hormones prior to age 14 years. The compelling reason for earlier initiation of GAHT, for example, might be to avoid prolonged pubertal suppression, given potential bone health concerns and the psychosocial implications of delaying puberty described in more detail in Chapter 12. Puberty is a time of significant brain and cognitive development. The potential neurodevelopmental impact of extended pubertal suppression in gender-diverse youth has been specifically studied as an area in need of continued study. God, these are just giving me everything to fucking read today. While GnRH analogs have been shown to be safe when used for the treatment of precocious puberty, there are concerns delaying exposure to sex hormones, endogenous or exogenous, at a time of peak bone mineralization may lead to decreased bone mineral density. Potential decrease in bone mineral density, as well as the clinical significance of any decrease, requires continued study. Let me highlight this. The potential negative psychosocial implications of not initiating puberty with peers may place additional stress on gender-diverse youth, although this has not been explicitly studied. When considering the timing of initiation of gender-affirming hormones, providers should compare the potential physical and psychological benefits and risks of starting treatment with the potential risks and benefits of delaying treatment. This process can help identify compelling factors that may warrant an individualized approach. Studies carried out with trans-masculine youth have demonstrated chest dysphoria is associated with higher rates of anxiety, depression, and distress, and can lead to functional limitations such as avoiding exercise or bathing. Testosterone, unfortunately, does little to alleviate this distress, although chest vascularization is an option for some individuals to address this distress long term. Studies with youth who sought chest vascularization surgery to alleviate chest dysphoria demonstrated good surgical outcomes, satisfaction with the results, and minimal regret during the study monitoring period. Just, God fucking damn it, I did it again. Oh my fucking god. Let me find where the fuck I left off. Sorry for that. Yeah, keep scrolling. What do you mean, Ross, that they didn't finish the study? I think they're saying is that some of these studies haven't been done, or they're limited in the data they have. And again, this is stuff I don't necessarily agree with. Where'd it go? Where were we at? We did that. We did that. We did that. Okay. I think we were in chest vascularization surgery can be considered in minors when clinically and developmentally appropriate as determined by a multidisciplinary team experienced in adolescent and gender development. See the relevant statements in this chapter. The duration or current use of testosterone therapy should not preclude surgery if otherwise indicated. The needs of some trans youth may be met by chest vascularization surgery alone. Breast augmentation may be needed by trans feminine youth, although there is less data about this procedure in youth, possibly due to fewer individuals requesting this procedure. GAHT, hormone therapy, gender-affirming hormone therapy, as I believe that. So I'm just going to say hormone therapy for that one. Specifically, estrogen can help with the development of breast tissue, and is recommended youth have a minimum of 12 months of hormone therapy or longer, as it is surgically indicated prior to breast augmentation, unless hormone therapy is not clinically indicated or is medically contraindicated, like taking estrogen would be bad for you. Data are limited in the optimal timing for initiating other gender-affirming surgical treatments in adolescents. This is partly due to the limited access to these treatments, which varies in different geographical locations. Data indicate rates of gender-affirming surgeries have increased since 2000, and there have been an increase in the number of trans-seeking vaginoplasty. A 2017 study of 20 WPATH-affiliated surgeons in the U.S. reported slightly more than half had performed vaginoplasty in minors. Limited data are available on the outcome. Actually, really want to read that one. Limited data are available on the outcomes of youth undergoing vaginoplasty. Small studies have reported improved psychosocial functioning and decreased gender dysphoria in adolescents who have undergone vaginoplasty. More shit to read. While the sample sizes are small, these studies suggest that there may be a benefit for some adolescents to have these procedures performed before the age of 18. Factors that may support pursuing these procedures for youth under 18 years of age include the increased availability of support from family members, greater ease of managing postoperative care prior to transitioning to tasks of early adulthood, such as entering university or the workforce, and safety concerns in public spaces, i.e. to reduce transphobic violence. More shit, just like, given the complexity and reversibility of these procedures, an assessment of the adolescent's ability to adhere to post-surgical care recommendations and to comprehend the long-term impact of these procedures on reproductive sexual functioning is crucial. Given the complexity of phalloplasty, creation of a neopenis, and the current high rates of complications in comparison to other gender-affirming surgical treatments, it is not recommended this surgery be considered in youth under 18 at this time. Well, thank God for that one. I'll give them that one. At least they can do that. No phalloplasty for under 18. Because phalloplasty isn't as good as vaginoplasty. Because vaginoplasty actually started as a way to recreate vaginas for women who had traumatic injuries to their vaginas. And we're trying to redo it. That's why we actually can do really well with that surgery. Additional key factors that should be taken into consideration when discussing the timing of interventions with youth and families are addressed in detail in statements 612A through F. For summary of the criteria recommendation. Okay, whatever. Okay, so that was adolescent. But what's the children's section here? Okay, looks like the children's section solely focuses on social transition. I don't see anything here about medical transition. And these statements of recommendation. That's good. For your gender, it's okay. Think of benefits of medical social transition. The kids one, I think we can realistically skip because we don't have to talk about the medical side of it so much. The closer, some of those studies were also longitudinal studies where they did have satisfaction over years. So it wasn't necessarily recent. Some of those studies that they cited did have longitudinal studies included. Okay. Right. And one of the reasons I'm deciding all this, like highlighting all this shit to read and to cite and to go back and review, is to see if they're actually citing it accurately. Again, it's not something I'm going to do all today. Hormones therapy. We're moving on to chapter 12. We're skipping the children's chapter because it's not necessary. Let me see how much of this is. Okay, we might run into some issues here. We're about to, those in chat who are already a bit ragey, I just read something quickly. Be prepared to rage some more. All right? These are statements of recommendations for hormone replacement therapy. God damn this stupid fucking USB-C VGA connector. Sorry. I had to beat my computer into submission so it would listen to me. Naughty computer monitor. Okay. Statements of recommendation. Oh, I have a feeling Closer and Ronset might be a bit upset here. All right. Let's get my monitor back up. Put on the right window. Okay. I'll do it. No, yeah, I'm doing it. We're doing it. I might as well. I'm going to read the statements of recommendations for both this section and the surgery section. And then I think I might have to cut it because my voice is like, I'm struggling right now. And I'm fucking starving. I haven't ate yet. Like, I woke up, got shit ready, and kind of like got with you guys because I was up late last night. All right. 12.1. We recommend healthcare professionals begin pubertal hormone suppression in eligible, transgender, and gender diverse adolescents after they first exhibit physical changes of puberty, tenor stage 2. We recommend healthcare professionals use gonadotropin releasing hormone, GnRH agonists, suppress endogenous sex hormones in eligible, transgender, and gender diverse people for whom puberty blocking is indicated. We suggest healthcare professionals prescribe progestins, oral or injectable depot for pubertal suspension in eligible transgender and gender diverse youth when GnRH agonists are neither available or are cost prohibitive. We suggest healthcare professionals prescribe GnRH agonists for suppression of sex steroid without concomitant sex steroid hormone replacement therapy in eligible transgender and gender diverse adolescents seeking such intervention and who are well into or who have completed pubertal development past tenor stage 3, but are either unsure about or who do not want to begin sex steroid hormone therapy. We recommend healthcare professionals prescribe sex hormone treatment regimens as part of gender-affirming treatment for eligible transgender and gender-diverse adolescents who are at least tenor stage 2 with parental guardian involvement, unless their involvement is determined to be harmful or unnecessary to the adolescent. That's the one I think you guys are going to rage at. Let's see who fucking gets mad at this. Get mad at this. Closer, tell me if 12.5 makes you mad. I'm going to continue. But Closer, Ron said, tell me if 12.5 makes you mad. Unless I'm reading it wrong. We recommend healthcare professionals measure hormone levels during gender-affirming treatment to ensure endogenous sex steroids are lowered and administered sex steroids are maintained at levels appropriate for the treatment goals of the transgender and gender-diverse populations according to the tenor state. We recommend healthcare professionals prescribe progestogens or GnRH agonists for eligible transgender and gender-diverse adolescents with a uterus to reduce dysphoria caused by their menstrual cycle when gender-affirming testosterone use is not yet indicated. We recommend healthcare providers involve professionals from multiple disciplines who are experts in transgender healthcare and in the management of care required for transgender and gender-diverse adolescents. 12.9. We recommend healthcare professionals institute regular clinical evaluations for physical changes and potential adverse reactions to sex steroid hormones, including laboratory monitoring of sex steroid hormones every 3 months during the first year of hormone therapy, or with dose changes until stable adult dosing is reached, followed by clinical and laboratory testing once or twice a year, once an adult maintenance dose is attained. 12.10. We recommend healthcare professionals inform and counsel all individuals seeking gender-affirming medical treatment about options available for fertility preservation prior to initiating puberty suppression and prior to treating with hormone therapy. Hey, at least that part's in there. 12.11. We recommend healthcare professionals evaluate and address medical conditions that can be exacerbated by lowered endogenous sex hormone concentrations and treatment with exogenous sex hormones before beginning treatment for transgender and gender-diverse people. We recommend healthcare professionals educate transgender and gender-diverse people undergoing gender-affirming treatment about the onset and time course of the physical changes induced by sex hormonal treatment. A lot of people don't. This part here, I think, is important because a lot of people who undergo treatment don't realize how long it takes for some of the changes to happen, like body fat distribution changes, breast growth, the feminizing of the skin, in hair, in different ways, things like that can take time. Like breast growth takes years. Some people think it takes months. I mean, you still start to see breast growth, but you're not going to get full breast development for a couple of years. It can sometimes take up to 5. 12.13, we recommend healthcare professionals not prescribe ethinyl estradiol for transgender and gender-diverse people as part of a gender-affirming hormone treatment. We recommend healthcare professionals prescribe transdermal estrogen for eligible transgender and gender-diverse people with higher risk of developing venous thromboembolism based on ages 45 or greater, or a previous history of venous thromboembolism when gender-affirming estrogen treatment is recommended. So for those who are older than 45, that makes sense because of the higher risk. We suggest healthcare professionals not prescribe conjugated estrogens in transgender and gender diverse people when estradiol is available as a component of gender-affirming hormonal treatment. We recommend healthcare professionals prescribe testosterone-lowering medications for eligible transgender and gender diverse people with testes who are taking estrogen as part of a hormonal treatment plan if the individual's goal is to approximate circulating sex hormone concentrations in cisgender women. We recommend healthcare professionals monitor hematocrit or hemoglobin in transgender and gender diverse people treated with testosterone. Recommend they collaborate with surgeons regarding hormone use before and after gender-affirming surgery. We suggest healthcare professionals counsel transgender and gender diverse people about the various options available for gender-affirming surgery as it's not indicated or may be contraindicated. We recommend healthcare professionals initiate and continue gender-affirming hormone therapy for eligible trans and gender diverse people who require the treatment due to demonstrated improvement in psychosocial functioning, quality of life. And 1221, we recommend healthcare professionals maintain existing hormone therapy if the transgender and gender diverse individuals' mental health deteriorates and assess the reasons for deterioration unless contraindicated. So, for eligibility criteria, which we went over the adolescents one earlier. Now, I'm not going to dig into the citations and the supporting statements on this because I can already feel my throat going, and we're almost 2 hours into this. And as much as I'd like to continue, I don't know if I can. So we're going to do this. We're going to move on to surgery, preoperative care, go to those recommendations. Let's see if anything is there that wasn't there before. Okay, there's 11 recommendations. For statements or recommendations regarding, this is for adults and adolescents. Remember, we've now moved the bar to Tanner Stage 2. So surgery and postoperative care for transgender surgeries. For gender-affirming surgeries is where we're at. Right, I'm a little too far in. Let me go out to 1. There we go. Statements of recommendation. 13.1. We recommend surgeons who perform gender-affirming surgical procedures have the following credentials. 1A, training and documented supervision in gender-affirming procedures, maintenance and active practice. I don't care about that. That's all what I would expect. 13.2. We recommend surgeons assess transgender and gender diverse people for risk factors associated with breast cancer prior to breast augmentation or mastectomy. We recommend surgeons inform trans and gender diverse people undergoing gender-affirming surgical procedures about aftercare requirements, travel and accommodations, and the importance of postoperative follow-up during the preoperative process. 13.4. We recommend surgeons confirm reproductive options have been discussed prior to gonadectomy in transgender and gender diverse people. We suggest surgeons consider offering gonadectomy in eligible trans and gender diverse adults when there is evidence they have tolerated a minimum of 6 months of hormone therapy, unless hormone replacement therapy or gonadal suppression is not clinically indicated, or the procedure is inconsistent with the patient's desires, goals, or expressions of individual gender identity. We suggest healthcare professionals consider gender-affirming genital procedures for eligible trans and gender diverse adults seeking these interventions, where there is evidence the individual has been stable on their current treatment regimen, which may include at least 6 months of hormone treatment or longer, with the period to achieve the desired surgical result, unless hormone therapy is not desired or is medically contraindicated. We recommend surgeons considering giving gender-affirming surgical interventions to eligible transgender and gender diverse adolescents when there is evidence of a multidisciplinary approach that includes mental health and medical professionals that have been involved in the decision-making process. We recommend surgeons consult a comprehensive multidisciplinary team of professionals in the field of transgender health when eligible trans and gender diverse people request individually customized, previously termed non-standard surgeries as part of gender-affirming surgical intervention. We suggest surgeons caring for transgender men and gender diverse people who have undergone 𝗦𝘂𝗽𝗍𝗀𝗍 or phalloplasty encourage lifelong urological follow-up. We recommend surgeons caring for transgender women and gender diverse people who have undergone vaginoplasty encourage follow-up with their primary surgeon, primary care physician, or gynecologist. And we recommend patients who regret their gender-related surgical interventions be managed by an expert multidisciplinary team. Hey, at least that's in there. All right. Yeah, I'm definitely going to have to go through and read some of these citations. So, I will say this much is if we go back up to the list, Again, this is the summary of the recommendations. The details of the recommendations are further below. Like, I skipped over those. Like, we read those for the adolescents because that's the more controversial shit. But I will say that this right here, 13.5, this is a huge change for adults. Previously, prior to surgery for in WPATH SOC7, to have a for gonadectomy. Okay, never mind. I misread that. Let's see. Hold on. Oh, I think it. So this one was 6 months before. I think. I don't remember. I think this was 6 months before for gonadectomy to have your testes removed. But it looks like they've bumped the recommendations from 12 months to 6 months for adults to be on hormones before having to have surgery. Because it used to be 12 months lived experience while on hormones. Actually, while I'm thinking about it, let me see what number was that? 13.5 and 13.6. Let's go to those ones. I want to see what these ones say. The supporting text, 13.6. Gender forming hormone therapy. Hold on. I really want to read this one because if they change that, that's going to really piss me off. If there was a reason for the 1 year, I wonder if they left the lived experience in. Because if they remove that, I think that's a big issue as well. The lived experience was in there for a reason. Gender affirming hormone therapy leads to anatomical physiological changes. The onset of anatomic effects, clitoral growth, vaginal mucosal atrophy may begin early after initiation of therapy, and peak effect is expected at 1 to 2 years. Depending upon the surgical result required, a period of hormone treatment may be required. Sufficient clitoral virilization prior to 𝐒𝐻𝐽𝐻𝐸 or phalloplasty are preferred. For psychological reasons and anatomic reasons or both. Breast growth and skin expansion prior to breast augmentation. For individuals who are not taking hormones prior to surgical interventions, it is important surgeons review the impact of this on the post-surgery. Hold on. I don't think SOC7 allowed surgery without hormones. That's interesting. I'm not sure if I'm okay with that. For individuals undergoing gonadectomy who are not taking hormones, a plan for hormone replacement can be developed with their prescribing professional prior to surgery. So if you're going to have your testes removed, you're going to have, even if you don't take estrogen, you're still going to have to take testosterone supplement because you've got to have them from someone. I know it's hard to read, but my voice probably doesn't help because my throat hurts. And hold on, let me do this. Live experience. Okay. I know before SOC7 required. Huh. I feel like they took it out. Like, no joke, I believe they took it out. No shit. Let me go. It would be in the section. Lecture 13. Is it seriously gone? No fucking way. That would be one of those things like I feel would be important to keep in. I understand why there are some people you could have edge cases that you don't need the lived experience to have surgery and to do that. You don't need to have the lived experience to start hormones, but normally prior you had to have the lived experience to do surgery. Wow, that's interesting. Huh. I'm actually kind of shocked right now. This is chapter 14 is for voice and communications. That's for like I'm clicking the wrong thing. I think they took it out. Yeah, I'm a bit it's a bit interesting. Actually, I normally don't do this on the fly, but I think it'll be interesting to hear from people. I'm going to drop the StreamYard link. I want to talk to people and get some insight on how they feel about this before we close this out. Because I think this is interesting. Oh my fucking god, this stupid fucking adapter again. I'm going to beat you like a rented mule. Alright. Thankful. Now it's fucking working again. Alright. Go back to your corner. Where's your home? Alright. Alright. So there's the link if anyone wants to come up and discuss this. I would really like to hear from people if they want to talk about this before I close the stream out. Oh no, please, Poop Knock. If you would like to come up, as long as you can kind of tone it down just a little bit, within YouTube terms of service, please. I will be appreciative of that. But no, I'll be the first to say I don't like this. I don't like the minimum age being removed. I absolutely do not like that. There being no actual age limit and it being put onto Tanner Stage 2, which I'm just going to go ahead and say fuck it for the purposes of this. Because I'm actually, let me prove to you that my stream's not monetized. Or wait, did they? Yeah, it's limited. So let me go ahead and request my review like I have to do for every fucking stream. So might as well do the review request. Okay, it's being requested. So since we're doing that, let's go ahead and pull this up so I can let you guys see what I'm talking about here. Actually, here's some statistics on it. We'll pull this up too. So this is for males. This is a male Tanner stage chart. It's actually a good one. Actually, I think I might have shown this one on. Wait, what's different? Is that the same thing? Okay, here we go. We're going to pull this one up because I think this one's the most fitting. All right, so stop screen, share, screen share, Chrome tab. Oh, which one is it? I think it's that one. So we're going to share this. So this is what the Tanner stages look like. So this is Tanner stage 1, which is pre-puberty, right? That's pre-puberty. Tanner stage 2, growth rate 2 inches a year or so. Testes increase in size and the skin of the scrotum redens. Age range, approximately 10 to 13 and a half years of age. This is your minimum cutoff now. This is your cutoff. That's for males. So where's my female one? Is that one on here? So this is the female one. Yeah, like I said, fuck the monetization's probably fucked already for this thing, so fuck it. This is the female one. Make sure it's up on the screen. All right, so this is the female one. So this is Tanner stage 1 for females. No pre-puberty, right? So Tanner stage 2, growth rate 2 inches a year, give or take. Breast buds begin, age range 8 to 13. Tanner stage 3, breasts and areola grow. Age 4, age 5 is basically adult, or finishing up final adult development of your breast. And then there's also this is more probably important for the purposes, because as the document was saying, it's focused more on those parts of the growth, gonad arc versus like body odor and pubic hair. Like that's not the defining factor. So the testes increasing in size, the breast bud development, that would be what they would look at for tender stage 2 development, which for females can start anywhere from age 14 to 11. Mean age, I think, is around 11. So there you go. That is the limit. That is our minimum cutoff now. That is the minimum cutoff. And actually, while I'm sitting here thinking about it, before I fucking forget, let's see. All right, I got it here. So here's what we're gonna do, because I have it. So Melanie, it doesn't mean that necessarily they're going to be prescribed it. There are other criteria that also have to be met to be prescribed puberty blockers or hormones or surgery. So those things also have to be met as part of the course. But one of the requirements of all the requirements, so here, let me go back to that. So everyone's on the same page, because I know we got some people who have jumped in and out. Before I pull up 7, let's go back to 8. Go back to 8. Let me go back to this section here. Go back to the statement of recommendations. So we will go back to this, and then I will pull up 8. Shit, I did that wrong. Oops. That would show you my Pornhub tab. That's bad. Anyway, that's a joke, obviously. Is it? Anyway, all right, so here we go. This is the recommendations for adolescents. So adolescents being defined as basically tender stage 2. So the following, I'll read again. The following recommendations are made regarding the requirements for gender-affirming medical and surgical treatment. All of them must be met. So again, as I said earlier, and I'll say it again, medical treatment would be puberty blockers, gender-affirming hormones, surgeries. So breast removal or breast augmentation, testes removal, orchiectomy, vaginoplasty, phalloplasty, those kind of things. Those would be all fall under the category of surgical treatment. Adam's apple shaving, facial feminization surgery, all that would be technically under surgical treatment. The medical treatment would be puberty blockers, hormones, other you have puberty blockers, gender hormones, and you also have medications that block your assigned at birth sex. So like if you're born male, you would take medications like estrogen, and you would take androgen blockers. I would pronounce it wrong. Anyway, to block your birth sex hormones because you still have your testes. Until you have an orchiectomy or you have full-on surgery, you're still giving off testosterone. Until you get rid of that, you have to block it. You can still do estrogen treatment. Without it, it's not as effective. But normally you would have that prescribed, and then in females you have similar in reverse. But to meet these requirements here, let me zoom in again. Oh shit, I did it wrong. One, I think was the sweet spot. So we have to meet all these. The one that I was saying here, and it's why I pulled up the pictures. 612F, the adolescent has reached tender stage 2 for puberty, the pubertal suppression to be initiated. Right? So you have to have at least that to start puberty suppression, which could be as young as 8, 9, 10, 11, 12, give or take, depending on when the child reaches that part of development. And in that section, we talked about, when we went to 612F, it talked about not just being like development of pubic hair and development, the breast part is starting. You're starting to actually go through puberty a bit before you suppress the puberty. And then what I don't actually like this document focuses a lot on is it's almost justifying, and if please someone in chat correct me if I'm wrong, it's almost justifying not doing long-term puberty suppression because of possible effects of puberty suppression on like bone growth and stuff. And almost the way they said doing puberty suppression for too long is bad. So you can do surgery sooner. Okay. Or you could do hormones sooner. Okay. But you've now made the cutoff for just puberty suppression. There's no real cutoff for hormones. So basically, you can do puberty suppression, you can do hormones, right? Like, it's not, there's no age. They literally put no age limit in here. And they justified why they put no age limit in here in that section. I knew this was going to piss me off when I did this stream. Like, I'm all for doing the right things to help trans people, to give them the surgeries, to treatments, whatever. To even help. I've worked with trans youth. Not like this, but I've worked with trans youth, and I've always taken a very slow and methodical approach to anything with that, because it's important to do it and analyze it, because that client I had, one of my clients I had that was wanting to transition, this was, before this, was wanting to go female to male, wanting to get transitioned to hormones. I think they were wanting to do full surgery, at least top surgery. And they were also having depression and anxiety issues. And I told them, we need to work on this first, because what if we go through all of this and nothing feels better? We have to address some of the anxiety and depression first. We really need to think about and be able to explain parts of why you feel this way and how you justify this. So at my first glance, I'm not happy with this document. I'm actually frustrated. I'm upset. I'm very upset. I'm pissed off. Closer, actually, I know that. So let me go a little medical with you, because I know some of this stuff, right? There are several ways to do vaginoplasty. One of them is what most people think of as the penile inversion technique. Is if you start, what Closer's saying here is if you start puberty blockers young, like 12, like say you start them early 10 or stage 2, you haven't really hit penile development yet. You will not have enough skin to have a functioning vaginal canal. Now, there are other methods. There's the one that was referenced where they take a section of the sigmoid colon and they use that to create the neovagina. It's actually a really cool technique. And one of the benefits being it can be, for some trans women, it can be self-lubricating. As if you have a situation where, whether you went through puberty or not, and you do have a smaller penis, you can still have a functioning vagina, because they use a section of the colon to create your vagina, right? So there are still ways to go through with it. But that is something you have to take into consideration, is that is a method you're wanting to use. And this is why that ability to do metacognition, to think about things and think about thinking and think about your life and think about shit like that. And not just the bare minimums and not just your day to day, and think about further ahead in life. That is crucial to decision making and consent, I would say, in this situation. So yeah, it's not impossible to help management. And there's a lot of issues with this document. This is the news. This is the new standards of care. I believe this has been unveiled, and this is what doctors, and that's what I have to work under, right? So how does Ken? Well, it's not technically Gabe. It's different. You still have two separate folds, but it's. I mean, if you want to get to it, we're all skin, we're all cells, we're all mean. If you really want to be morbid, because the atoms will never be able to touch one another because the electrons repel one another, you actually never touch, and you can never actually feel close or be able to connect with another person ever, because of subatomic and atomic repulsion of atoms. You'll never touch. So, like, if you want to get real technical, like, it's skin, or it's the different sections of skin. Just like the phalloplasty, you can use part of your arm skin section for. So it's complicated. There's a lot of shit that can go into it. I mean, if it's you can call it a funny joke if you want. Like, I'm not saying you can't laugh at it. I mean, it's not necessarily improper. I mean, you can make fun of whatever. It's not my place to limit your humor. But this is a problem. So how does Ken work under these restrictions, right? How do I because the NASW is going to necessarily say you have to follow the current medical guidance of whatever you're practicing. Current medical guidance, WPATH is the agency, the body that sets transgender healthcare. If I have a trans client, I have to work underneath these. How do I work underneath these? This is where the job can be very hard, separating the personal and the professional. I've had clients come in and bitch to me about politics or talk about this and that, or how, I had one client talk to me about the January 6th stuff during the transition to the election. There were multiple sessions we talked about that, and my personal views on that were different. But in session, I had to change my tune. I had to do things the right way. I couldn't just be like, "Oh, you fucking retarded." That's not how it works. That's not necessarily I disagree with him. It was more of a family thing, but because of what was going on. But you have to be able to do that because of what it is, because of what the job is. So I have to take my personal stuff and set it aside and go, all right, how do I practice ethically? But practice ethically in a way that's not going to harm my client. Because the way I see it is some of this will harm my client if I did it to the T. But I can still practice ethically in the framework. Because I have to, as long as I do it the right way. Just like it says, I have to be affirming. I can't tell the person, to not. And then again, I would never tell a client, oh, you're not trans, or you're not this, you're not that. If we're relating to gender identity. Just like I wouldn't just tell someone off the bat, oh no, you're not a monkey. You're not a T-Rex. Someone said it earlier in chat. Because it doesn't work. You have to, yes, thank you for smash that like button, hit the super chat, donate locals, supportken.com takes you straight to my local page. Let me do the grip real quick. There you go. Super chat if you like what you hear, like the stream. You don't have to like the content necessarily because it's fucking irritating and frustrating. But if you like the content today, or if you like the streamer, you can support me that way. So, but yes, this is fucking difficult. Like, this makes my job difficult. This makes what I have to do difficult. Not because I necessarily have an issue with trans people. I have no problem working with trans people. I work with trans kids. I've worked with trans adults. I got friends who are there's not an issue with me. I've got friends who are gay. I've worked with people who are gay. I have, like, my Psychology Today profile was fucking said kink friendly on it. I was like kink friendly, opened up, different shit like that. I had one person come in a poly relationship or in an open relationship, like, because they found me at my old job on Psych Today because of that. Like, I'm one of the most accepting people you'll run into. But my issue is I'm always worried about my client's safety and health and making sure that they were done, and that when they walk out the door, when they're done with my care, that I have set them up for success to the level that I can. There's a limit to how effective I'm going to be. There's a limit to how good my work will be, because most of it lays on the client to do the work. But if I put the things in place to set them up for success that are going to set them up for failure, I have failed them. Some of this would fail clients of mine. How do I work around it? I will figure it out when the time comes. I'm frustrated. I'm not done because I got 260 pages I'm going to read in my spare time sometime and go through all the rest of the standards. But as far as, because I work primarily with youth, the standards regarding youth, and I've worked with trans youth, and it comes up semi-decently. Like, it comes up, gender identity or sexuality stuff, like I'm gay or this or that. Like, it comes up because this is a job. So I have to know how to work within the current ethics and the current standards. This is one of them. So how do I do that appropriately? How do I make sure I don't ever want to put my personal beliefs ahead of the client? Never, ever do that. Trust me, I've set aside my own personal issues many, many times for clients. Many times I've gone, whoa, I do not agree with that, or I do not like that. That's not okay. But I've done it because I had to. And it's not that I'm not okay with it. I like being able to have someone come into my office, sit down and go, Mr. Ken, I like that you listen to me. I like that you're not just telling me I'm dumb or I'm stupid or that you're not listening to me. And I've had people come in with delusions or with bad ideas or wanting to make poor decisions. And I've helped change that because that's what I do. But I want them to feel comfortable enough to do it, because if they don't want to walk in the office, then they're not going to do it. My concern is as far as I know I can handle my side of it professionally. That's not the part that scares me. But truthfully, the part that scares me is kids coming in really wanting to push the issue. And in the professional look, in the professional light, not my personal opinion, in the professional opinion, they're wanting to rush it because, and some of the document wasn't necessarily wrong. They are addressing ways to mitigate stuff, but there are things there I don't like. Maybe it's me being old school. Maybe it's me being right. I don't know. But, you do have to deal with things like dealing with other mental health issues first, like depression, anxiety. If the kid's wanting to rush it, and, the parents, or if the parents behind them and saying, you need to make this happen for my kid. You need to write a letter. You need to do this, this, and that. It's because I would say, that I would have concerns if we push this. What could happen to you if you haven't considered the full consequences of it? Will be probably how I look at it, and how the kid responds, the parents respond. You never know when the next board complaint will be. So while we sit on this really depressing topic for a second, let me pull up something to make you guys maybe laugh a little bit, or maybe go, what the fuck? This is supposed to be my stream. Is this it? Oh, that's the wrong one. Is it this one? Nope. I think it was this one. Hold on. I have a really, really fucked up but funny. Here we go. I think I found it. I have to redact a couple things real quick in it. But I'm going to make you guys either laugh or go, what the fuck is wrong with this person? Real quick. To kind of lighten the mood from this. This is just a little bit of an intro into next stream. Because this was supposed to be kind of a funny... today's stream was supposed to be funny and lighthearted a little bit. Or kind of to laugh and make fun of shit. But that didn't happen now, did it? So what I'm going to do is I'm going to redact some of the document real quick. All right. So that way we can go through it. And I think y'all will like it. Because it's pretty fucked up. And I thought it was, I don't want to say it's funny because of what it is. But I read it and I went, you can't be fucking serious. Someone cannot be that stupid. You ever have that where you see go, someone cannot be that stupid that they would do something in their professional light that would actually make them make decisions like this at work. Like, so what I'm going to do is redact the rest of this real quick because I think you guys will find this is hilarious. This is great. I read this and I'm like, there's no fucking way this happened. And then I realized, yes, there's a way it happened because people are that fucking stupid. So we'll get a kind of we'll end on this because I think you guys will find it funny, or at least go, what the hell's wrong with this person? I want to redact the personal information so that way no one gets, because it is a board complaint. So it's one of several board complaints that I found that I thought might be interesting. There's just a couple more things I have to redact because it references locations. I still don't believe that this actually happened. This has to be fake to me. This like has to be fake. Yeah, it is a 𝗓𝗂𝗧. It is a 𝗓𝗓𝗧, dude. I cannot believe both in the weight and in what you're about to see. I saw this one day. It worked months ago. I was reading board complaints for fun because had some downtime, and I was like, "Oh my god, this would make great for a stream. This would be an amazing stream to do with this." All right. All right. I think I've almost got it. Well, I just tried to block out shit so people can't just look them up. I don't want anyone to get like doxxed or fucked with because there is legit an address, home address in this document. Okay. Apply. Okay. Perfect. Okay. Oh shit, I'm on. But I won't go to that page. Anyway. All right. You guys ready for this? This is great. This is great. Okay. This is fucked up. I'm just going to say, I've done some things I've questioned myself on. Not unethical, but like, is that the best way to handle my day? Is that the best way to handle my situation? Maybe not. But this is something I can say I would never fucking do. All right. You should be very scared. All right. This is an administrative complaint from the state of Florida Board of Clinical Social Work, Marriage, Family Therapy, and Mental Health Counseling. So this is a case against a person who was a registered clinical social work intern. So let me define this real quick because I've had to explain this before when people shit on me. Is when you're a registered intern is different than being an intern while you're in grad school. An intern while you're in grad school to get your degree is you're learning to get your degree. Registered intern for the purposes of this, and in most states is you're practicing. You're not like just watching. You're actually doing the therapy, right? You're doing the work. You meet with a supervisor. You have to do 100 hours in Florida. You have to do 100 hours of supervision, and you have to do 1,500 hours of clinical interaction. And it can take. You have to do it in no less than 2 years. You have up to 5 years, but no less than 2 years to do it. Right? This is the same title I hold. Right? But doesn't mean I don't do. It's not like someone's sitting over my shoulder watching me do therapy. Like I'm on my own. Right? Same with this guy. They're on their own. They're usually doing their own shit. You're not like having someone stare down you. Even when I was in grad school, like not like someone was like staring down my neck the whole time. They're like, "What are you doing, Mr. Ken? What are you doing, Ken? What are you doing? You doing things right?" So, just to give you an idea of what this is. So this person is doing therapy because they're an intern doesn't mean they're not doing therapy or not doing whatever their role is, right? Comes now, petitioner, Department of Health, and files this administrative complaint before the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling. Hereafter, board against respondent blank, who's a registered clinical social work intern, and in support thereof alleges petitioner is this. Hold on, let me move to that so I can highlight some of these hilarious fucking things. Petitioner is the state agency charged with regulating the practice of clinical social work pursuant to Section 220.43 Florida Statutes, Chapter 456, Florida Statutes, and Chapter 491 Florida Statutes. At all times material to this complaint, respondent was a registered clinical social work intern within the state of Florida, having issued the license number ISW blank. Respondent's address of record is blank. They told you how to do. You're going to see what they did, Melanie. You're going to see. It gets good. Okay. And it gets really good. At all times material, respondent was employed by blank county schools as a registered clinical social work intern at blank junior senior high school in the location. At all times, patient AK was a student at the school. So I know which ones are which. So it was a student at the school. On or about October 18th, 2019, respondent provided treatment to AK in a closed-door setting at the school. Respondent failed to provide patient AK with informed consent. That's actually kind of a big deal. Yeah, well, I grabbed all of them from Florida because that's the one I know how to access the complaints thing and find the good ones. Number 8, respondent did not evaluate patient AK or document the treatment with patient AK. Number 9, the minimum standards of performance in clinical social work require a practitioner to provide informed consent to a patient prior to beginning treatment. 10, the minimum standards of performance in clinical social work require that a practitioner evaluate a patient in the initial treatment session and document treatment. That is actually true. Let me back out to 180. I went in too far. I'm inside too far. Okay. on number 11. We're getting there, Joji. It gets worse. It gets worse. On or about October 22nd, 2019, patient AK presented to the blank guidance office. Respondent began speaking to patient AK in a non-confidential setting. 13. Respondent advised patient AK to sleep with her boyfriend's best friend and or to start a rumor that patient AK was pregnant. This is the therapist. Respondent in this setting is the therapist. Remember this. This is the social 𝐅𝐸𝐸𝐽𝐽, the registered clinical social work intern. Your therapist is respondent. Right? Remember that. That's your respondent for the purposes of this document. The therapist advised patient AK to sleep with her boyfriend's best friend and or start a rumor that patient AK was pregnant. It gets worse. It gets worse. So that was on October 22nd. On or about October 24th, respondent approached patient AK in the school's cafeteria while patient AK was sitting with other students. Okay? It gets worse. Without patient AK's consent, respondent placed his hand on patient's AK's shoulder and or back. Okay? This is getting a bit worse. Never touch a client without their consent. Okay? Ever. Number 16. So, I can't help but laugh at this because this just gets so fucking... I can never imagine doing this. I can think of this being... Only situation I can think of this being as a joke, and the person has no idea of how to do shit. Yeah, what the fuck, Florida? 16. Respondent disclosed the male students sitting at the table that patient AK was single and or the male students should, quote, get with patient AK. The therapist disclosed the male student sitting at the table that patient AK was single and or the male student should get with patient AK. This is a junior, senior high school. This is a high school. It gets worse. It gets worse, guys. Number 17. This is where I think the worst part of it gets, right? The rest of it's kind of boring. This is the worst part coming up. I'm fucking horrible for laughing at this, but I can never imagine doing this with a client. Closer's like, what the fuck? Everyone's fucking... Number 17. Respondent. The therapist also disclosed that patient AK's parents would let a male student move in with patient AK and or have intercourse with her. Right? So the therapist is telling these other male students that the patient's parent... I know, Melanie. I know. This cannot be fucking real. It gets worse. It gets worse. Okay, we're not at the worst part yet. Well, maybe we are. At least the funny part's coming up. All right. I'm so sorry that we're doing this. 18. Respondent disclosed that patient AK's father would install a, quote, stripper pole. The therapist disclosed that the patient's father would install a stripper pole. Oh my fucking God. I can't believe this. It's just like, I know, buddy. I know. It seems like Reddit shenanigans. This is like, you can't make this shit up. Like, this cannot be real. Like, it is. Is this Rakina? Sir, what are you doing? Oh, I'm fucking dying. Oh, this is too good. All right. Hold on. That was 18. 19. The minimum standards of performance in clinical social work require that a practitioner refrain from using derogatory language in the written, verbal, or electronic communications to or about a client. Yeah. Was any of that derogatory? The well-known therapeutic stripper pole. I have one in my office. I didn't know pimps were regulated under mental health law in Florida. God damn it. This is awful. I know. This is just one of fucking many. Unfortunately, I have yet to run into one this crazy. This is the craziest one I've run into. Other ones are like educational, like here's what happens if you use too much alcohol, or here's other things like why you shouldn't sext clients. Like that is one I found. But this is the best one I've ever found. The minimum standards of performance in clinical social work require that a practitioner refrain from engaging in physical contact with clients when there's a possibility of psychological harm to the client as a result of the contact. Fair enough. It doesn't go into the client's background or any psychological issues in this document, but that's a good point. The minimum standards of performance in clinical social work require that a practitioner set clear, appropriate, and culturally sensitive boundaries when engaging in appropriate physical contact. I think that's not a big thing to ask. 22. The minimum standards of performance in clinical social work require that a practitioner refrain from disclosing confidential information obtained in accordance with professional services, except for compelling professional reasons. One of those reasons is not trying to hook up your teenage client with other teenagers. Well, shit. I guess I should have known that. Oops. Yeah, I can't believe this is real. Section 491, for statutes provide that failing to meet the minimum standards of performance in professional activities when measured against gender prevailing peer performance constitutes grounds for discipline. You believe they disciplined this pimp? I know, right? Respondent failed to meet the minimum standards of performance in clinical social work when measured against generally prevailing peer performance when the respondent did one or more of the following things. So this is what they're filing the report and disciplining him with, right? Failed to provide informed consent to patient AK, which actually that one's a really big deal. I'll give you that one. That is a big deal. You have to do that, whether they're an adult or a child or a teenager, whatever. You got to get consent to do therapy. Usually you got to get that documented. You make that mistake once and you never do it again, so you never get one of these reports filed. Failure to evaluate patient AK and document the treatment provided. Advise patient AK to sleep with her boyfriend's best friend and or start rumors that she was pregnant. Is that against generally prevailing peer performance? I didn't know that. Touch patient AK on her shoulder or back without her consent. I guess that's against generally prevailing. I think this person I can look it up. I'm pretty sure this person gave up their license or their license removed. Because when you're still a registered intern, they can fuck with you a bit more. I think this one will be one of those things where it's not like, oh, you're getting a small fine. I think this one's like, you're fucked. Honestly, I might be able to find the board recording audio where they do this one. Oh my god, I should find that. Because they record the board meetings where they do these. Oh fucking Christ, I should find that. Why didn't I think of that? Oh fuck, that's amazing. Disclosed to male students that patient AK was single and in order that they should, quote, get with her. F. Disclosing to male students that patient AK's parents would let a male student live with patient AK and or have intercourse with her, and or disclose that patient AK's father would install a stripper pole. Hoopnock's like, please. Fuck. Hold on. I don't know if I could do it right now. Hold on. If I can find this in like 5 minutes, I will do it. I'll have to skim through the audio. But if I can find this bitch, we'll do this live. We will do this. And we will fucking laugh for the rest of the goddamn day. Because if he actually appeared in front of the board and didn't just say, I'm going to just go ahead and give up my license. Hold on. I need to pull this down real quick so I can look at the name without you guys seeing it. Because I left one part of the name uncensored so I could. Okay. Let me see if I can find this. God help me if I can find this. This would make my fucking day. Board, this one. Respondent's last name is that. First name is that. Sorry guys, I'm not giving you the name. Search. Okay. The only thing I see is the complaint was filed. So here's what I can do. I know when the complaint was filed. I can look up meetings, past meeting. You go back a couple years because it's a couple years ago. It was filed. Okay, so I need to come into the next year. Oh, fucking help me if I find this. This would be amazing. That was filed that day. Check that. Wait, nope. Check that one. Check that one. That one. Then, oh shit, wrong button. Hold on. I'm seeing if I can find it. Hold on. Agenda minute. I gotta see if his name's on the agenda. Because if his name's on the agenda, then I can say yes. I can look through that audio and find it. Okay. It's not in that one. No, it's not in that one. We'll check the next early next year. Early next year. I will fucking find this thing. I will find this bitch. Hold on. Agenda, full minutes. Agenda, full minutes. They may have just dropped the complaint because maybe he didn't have enough to actually. Maybe it wasn't legit. But let me just check the probable causes for the year. The probable cause meeting. Because if his ass is in there, we're gonna fucking find it live. I don't care how long it takes. We're gonna find the bitch. Because general business meeting. Come on, bitches, where you at? Wait. Did we really go that long without a fucking meeting? Goddamn. I guess we did. Probably. Okay. Let me see if I can find this bitch. Hold on. So that one was canceled. That one's not it. No. Motions. Like a basic bitch board meeting. Federation. No. Fuck. Oh god, I was hoping they would have his ass on the meeting. It might not have been public. Because sometimes they happens is if it's a meeting where if it's a disciplinary thing they can't do publicly, they'll do it in private. I am not seeing his thing publicly. That's really shitty. I'm going to the last couple that I know of. Because I don't think they would let it go for 2 years before seeing it. Fuck. That would have been pretty damn amazing. Alright. Sorry, blue ball, you guys. Sorry on that one. So let's finish the document. I think. Alright. So here's where we left. Here's where we leave off. Based on the foregoing, respondent violated section 491.009(1)R. Wherefore, the petitioner requests respectfully the board enter an order imposing one or more of the following penalties. So this is the penalties they suggested. Permanent revocation or suspension of respondent's license, restriction of practice, imposition of an administrative fine, issuance of a reprimand, placement of the respondent on probation, corrective action, refund of fees billed or collected, remedial education, and or any other relief the board deems appropriate. That's what they were entered an order imposing one of those or more. Right? So, the lesson learned today, and then this is the signature of the Attorney General or whatever. So, I thought that might lighten things up a bit. Given, I'm so sad that fucking board meeting wasn't public or wasn't done. He might have just fucking resigned his license and it just never got or I mean, there's still a couple more months I could check. Please, Lord, let this not be real. I wanted to laugh about it, but it would be kind of relieved if it was made up. Yeah. This is one of those things where. So here's the thing. As I'm gonna take a small stance real quick. When I went to grad school, I had already done lived my life a little bit. I had worked in different fields. I've been a volunteer firefighter. I'd been an EMT. I had done, been in the military. I had done some other stuff with my life. I had worked in different management positions. I had life experience, right? So I was one of the older people in grad school, quote, compared to the rest of my cohort. There's about 200 people in my cohort. Because you basically you go to school with the same 200 people for the whole 2 years of the program, basically. It's not like different people come, like you come in as a cohort, you leave as a cohort, usually, unless you fail out. Coming in as someone who had life experience, I had a different perspective on the clinical and on different topics and different subjects than the people who went high school, undergrad, grad, and had never lived life. Just like 𝗏𝗏𝗏𝗏 talks about when he talks about people becoming lawyers and them being real young and like going from high school to college to law school. Like, how are you going to help that person navigate a divorce? How are you going to help that person do that? Like, I'm pretty good at helping people deal with trauma because I was a firefighter. I was an EMT. I've watched people die in front of me. I've had dead bodies in front of me when I was 16 years old because I was an EMT at 16 years old because Pennsylvania was fucking awesome. And you could get licensed at 16. I was one of the younger EMTs in my area. I was the youngest EMT in my department, in my fire department. Because it was a volunteer department. So I had seen shit and shit accessories. I've seen people die. I've watched people go through horrific traumas. I watched a dad screaming and bawling because his 12-year-old son was dying in a car, and he required 2 or 3 firefighters to hold him back to get to the vehicle because he wanted to see his son. Like, I've seen some pretty shitty stuff. Like, I can understand trauma a bit. That's why I'm pretty decent with working with trauma. It was something that I think benefits me in being a therapist. And I tell my clients all the time, a lot of the shit I do in therapy has nothing to do with any of the books I've ever read. Has nothing to do with that shit. A lot of the shit comes, like, I legitimately use safety training shit from being a firefighter as a therapeutic tool. Because it puts the point in clear language that makes sense and has a practical application. Why wouldn't you use that as an explanation? Right? Scene safety. I use scene safety as a tool to talk about why we have to do self-care and why taking care of ourselves is more important than worrying about other people. Instead of not taking care of yourself. Why, if you don't take care of yourself, you've now become, one of the people that need taken care of, right? I use shit like that. I use stuff like, in management, dealing with employees, working, doing other things, and how they all apply. And using that with teenagers and kids in ways that work. I still don't understand how it works, but it fucking does. But it gets the message through, and they learn something from it. And I feel I had an edge up on some of my cohort that was like, because we had an argument and disagreement in our lifespan development class. I still remember it. One chick who was one of those kids who had got high school, had their BSW, or I think their bachelor's of social work, and was coming into their master's, or they had worked in another field or something like that. We were both in the same class, talking about bullying and like lifespan development, like in the teenage years or childhood. And this person was wanting the school to do everything, wanting the school to take care of bullying. And I pushed back and I said, it's not on the school to take care of the bully. It's not to deal with the bullying. You have to teach the kid, you have to teach the person how to deal with the emotions and how to deal with interactions like that. Because the school will fail, the system will fail. You have to have something in place that you can use to have your safety taking priority. You put it first. You can't depend on another person to put your safety ahead of it. You have to be responsible for your own safety and your own security. And like, it was like almost a foreign concept to this person when I explained it that way. And like, I saw the wheels tick a little bit, and they were kind of like, I didn't think about it that way. And I'm like, yep, because I'm not saying, you teach the kid to get in the fights, but if the kid gets bullied, you have to do something. You have to, give them the tools they need to succeed. Because if you expect them to rely on someone else, then they're going to be relying on someone else for the rest of their life. And when that person fails to follow through, it's going to put them in a worse situation. So you have to take care of yourself first. And sometimes that's throwing a punch and standing up to the bully because they hit you first, but you defended yourself even though you get suspended, then that's fine. Shoji says, so to make good therapists, we need to traumatize a bunch of 16-year-olds. Got it. No, you need a bunch of people who have life experience. For me, and some of that stuff I did see as a firefighter, a little was a bit traumatic. I do have, I don't want to say PTSD, but like I have recall of some of those events. Like certain things will trigger the recall of those events, and I'll feel like I'm back there, and the emotions will rush over. It is a bit stressful sometimes. It doesn't happen all the time, but there are certain things that will trigger that for me, and it sucks. But you have to have people who have lived, I think, a little bit, even if they've only lived for a few years in like the real world, quote unquote. I don't think having people in any profession go from high school to college to grad school to med school or whatever, because if you go like high school to college to med school, right, become a doctor, you haven't lived, someone has something wrong with their hand, like, oh, we'll amputate the hand. That's an easy fix. But you don't consider the real life impacts on it, because maybe before you went to med school, you swung a hammer, you knew what it was like to work, you knew how important it was to have your hands, right? But as a doctor who hasn't lived and doesn't understand that, like, oh, we'll just cut the hand off, it's not a big deal. We'll make sure he's good, he lives, but how's he going to pay for his bills? How's he going to live life? Now you might throw that person into depression and suicide because you've taken away their source of income in their hand, and you didn't put any extra effort into taking care of their hand. Like, that's just a simple example. I would suggest, doing things, if you're going to go into professions like this, I would suggest doing something, having lived a little bit. Don't go out of high school and straight into college. Or if you do go into college, work a little bit before you go into something like this. Because like I said before, I could say something in a counseling session that can ruin someone's life. I'm always very aware of that. I can say the wrong thing and fuck someone's life up for a long time. It's honestly a really scary power to have, because I don't want to be responsible for fucking someone's life up. My job and my goal is to make people's lives better, help them make their own lives better. I love that about my job. So having some sort of experience in life, has given me the insight to say, I know the impacts I'm having. I know what it's like. Or I have some experience of what it's like to deal with situations, or the way I've dealt. Like, I'm not just giving something out of a textbook and reciting, well, here's an example of how you can deal with shit from my textbook. I can go, no, here's a way you can deal with shit in real life. And it hits harder and it hits home much better than anything else I can say. Anything else I can do, right? So that's why I'm really adamant about stuff like that, because it really makes a difference. And I think the quality of care you're going to get. I'm not saying I'm great at what I do. I think I'm okay at what I do. My clients love me, and I'm happy that they do. I've yet to get really true negative feedback, and I beg for it. I literally beg for it. I'm like, if you have something to bitch about me for, I want you to lay into me. I've begged kids to cuss and swear at me and use profanity at me for role play scenarios. Wouldn't do it. They refused to do it because they didn't want to disrespect me. And I was like, no, you can't. It's like the one time you're allowed to do it, and they didn't. Like, you're given permission. You're given permission to swear at me, use profanity, use any swear word, curse word, no matter how inappropriate. Here's your pregame music, because I'm going to show you how to react. Like, it was an educational thing, and I could not get a single kid to do it when I was working that day. It was fucking hilarious. I was actually frustrated because I was like, I just don't want you to fucking swear at me. It wasn't that big a deal. Like, I just need one of you to swear at me and insult me, like, to try and hurt my feelings. I wanted them to, like, make fun of my look, make fun of my time. I don't care, but because I'm going to show you how to deal with it. It's like a teaching exercise. And so I know my patients respect me, or my clients respect me. Like, they like the work I do. They like interacting with me. They hate it when they can't see me for whatever reason, or, they wish they could still work with me after they leave, or they go somewhere else, or they move, and I know that some of them worry about finding a good therapist, because sometimes it's hard to find. I'm not saying I'm a great therapist. I think I'm okay. My expectations are, I go to work. I as long as every day I can get up and I do my job, and I'm not like, I don't want to go to work today because I hate my work. The moment I do that, I will never work in the field again, because I don't ever want to get that bad. Because then I don't want to, because if I'm going to give shit work, and do shit work at work. Who's a great therapist in your estimation? Is like citing a specific person or like as a concept? I mean, a great therapist is going to be subjective. To me, a great therapist connects with their client in a way to where, I mean, I don't want to call myself a great therapist because one, I don't like complimenting myself because I don't want to seem conceited. And two, it's not my place to say whether I'm good or not. The people who think I'm good are my clients. They're the people who truly matter. Their opinions are the utmost important. Any boss of mine, they cannot like me or not. As long as my clients believe I'm doing my job right for them, I'm following my rules, following my codes of ethics and all that. As long as I'm doing that, my clients are the ones whose opinions matter. Everyone else, I don't fucking care. Coworkers, other therapists, oh, you suck at what you do. Well, my clients like what I'm doing and it's working. The parents like what I'm doing. The siblings like what I'm doing. That's helping them work together to improve. None of it's negative. That's what matters. So as a concept, I would say a great therapist is one who, like I had mentioned a couple months ago, I had a client where when I asked for their no bullshit answer about whether or not they were not okay, and they knew what I meant, they were willing to tell me they're not okay. They weren't going to hide it. They knew that they were going to take me away from my vacation day that day. That was supposed to be off that day. They knew I was going to drive 40 minutes to work. But when I asked for that answer, they gave it. Because they knew I wouldn't ask it if it wasn't important. Because they trusted me to do my job right. Even though they were feeling guilty about bringing me into work. They knew I was doing what was right for them. And they respected the shit out of me for that. They were happy that I did it, even though they felt bad about it. They knew they needed the help. After the fact, they realized, yeah, I was in a bad spot. Thank you for doing it. I still feel bad about bringing you in. And I told them it's not your, I'll work when I want to. I will come in. I will do what I need to, as much as I need to. As little or as much as I feel is necessary to take care of you. Each person gets individualized treatment. Is little or as much therapy is needed for each person. As long as my clients think I'm doing the right thing, then I'm okay. Melanie, personally, I think you have to have a genuine love of people. I agree. I love people. I love working with the kids I work with. I love the population because I remember being a teenager without so much guidance and really getting my ass handed to me a few times, situationally, not necessarily physically, but putting myself in situations and not that my parents are bad parents. I love my parents, but I isolated myself a lot as a kid. I spent a lot of time playing video games. I spent a lot of time not having someone I could go to, except a friend or two, to confide in, to help me with my shit. Having a therapist that when I was a kid or teenager would have been, I had a couple of different points occasionally, but it wasn't real therapy. It's like talking to the guidance counselor a couple of times maybe, or I had a therapist at one point for a small period of time when I was not doing so hot when I was 12. The rest of it, I went unguided. I needed guidance. I needed therapy. Bad. I can see kids going in the wrong directions. I can see kids who need help. And probably the hardest part of the job is kids who don't want the help, who aren't ready for the help, because they can't force it on them. They have to be willing to take the steps. And that's why I probably share a bit more about my personal self, and a bit more open about who I am, so they can connect with me. It's not like I'm talking about like deep details of my personal life, but there are some times where I bring up things that are important to the concept of therapy and making the connection and building the rapport to make the therapy effective, to get them to take the next step. They take the next step. It wasn't negative. It didn't hurt them. It was appropriate. It followed the ethical guideline. Do most people do it? No. But I'm not most people. I'll do what's right for my clients every day. You'll never find me not do the right thing for my clients. I love what I do. I want to see all my clients succeed. Some of them have deep traumas. Some of them have a lot of baggage. And that's a lot to bring into a counseling session sometimes. It's a lot to take home, because sometimes the work goes home with you. I think a good therapist or a great therapist is just someone who you as the client can trust that they're trying to help, they're doing the right thing, and you want to go back to them, that you feel they're doing the right thing, that you're not just going, and I've heard this from so many kids, that their therapists go, how does that make you feel? And just write notes and shit all the time. And that's like a good chunk of their session. And there's no real engagement. And it's just them bitching for an hour. And it's like, no. Come and do a therapy session with Mr. Ken. I promise you it will be so much different. Like, therapy sessions with me, I'm asking like multifaceted questions. I'm asking shit like, all right, so I'm going to push back. I'm going to push back harder than you can imagine on some of this stuff. And it's for fucking good reason. And my clients love it. Even though it's hard sometimes. Like, I have the example of I had a client who had done something. They were supposed to take a drug test. It was kind of it was causing issues for them to take the drug test. And I put the decision in their hand. I was like, I'm gonna leave it up to you to whether or not to take the drug test, and I want you to justify it. And they were pissed because I wouldn't make the decision for them. They were pissed. They were mad at me. Like, Mr. Ken, just have me take the test. Just tell me to take the test. Just make a decision, Mr. Ken. I'm like, no, it's on you to do it because I want you to do the work. I made them do that for 2 days. They were pissed, but they were happy I did it because it made them make the right decision for themselves and learn how to practice decision making, to do the right things for themselves. They were able to rationally make the decision. It wasn't done with cognitive distortions. It wasn't done with those thinking errors. It was done in a healthy manner. They could back it up. And I told them, I will back up the decision to say no to the drug test, and I will explain it where necessary to the people who need to hear it limitedly because I know you're doing the right thing. The drug test really didn't matter in the long run. Someone else wanted it. Whatever, fine. But when I did it that way, that 2 days of them having to sit on it was 2 days where they got to practice really important life skills. And it really made them reflect on the consequences of their actions, because I knew it was going to probably pop positive. They knew it was probably going to pop positive. And they were worried about the social consequences of it from the staff, from the other people, from, oh, you had a positive drug test. And being treated differently from it. And that's a real consequence. And that's going to negatively impact their behavior while they're staying with us. So what do I do? Okay, you don't want to take the test? Tell me why. Give me good reasons why. Show me it's worth putting the trust in you. And they did. And I put it up there. Was it risky? Sure. A little bit. Could it have backfired on me? Sure. A little bit. But did I make the effort to give my client a way to show them I'm not just here to listen and just go, How does that make you feel? Because so many people fucking hate that kind of therapist. As a therapist, it has been annoying when I've had therapists like that. Like, I love engagement. Like, I've had to apologize to clients because I'll talk for sometimes 5 to 10 minutes explaining something or talking about a concept or being supportive or being engaged and saying, this is why here's how what you're doing is so helpful to you, and just reinforcing the shit and helping them and realizing how important they are or why they're loved. And when I do that, and I'm like, I'm sorry to talk for so long, but I just want you to understand why I'm explaining this to you. And they're fine with that. They love to hear that sometimes. And sometimes they're like, oh, you talk a little bit, Mr. Ken. I'm like, okay, I'll try to cut back. But most of the time they don't mind. Because they get their time to talk and we have the engagement. We're both communicating during the session. That's what matters. It's just back and forth. There's engagement. It's me showing I'm actually listening and not just taking notes. And yeah, I take notes because I need to take notes to make sure I remember important details. But I'm taking notes to say, and I tell my clients that first time I meet them, sometimes I'm going to look down and write notes. Not because I'm ignoring you, because the things you're telling me, some of them are going to be really important for me to remember, and I want to make sure I do not forget those. So I will write those down. I will still listen if I'm not sure I heard something. I'll ask you to repeat it. But I want to take notes so I don't forget anything, because some of these things are important. If they're important for you to tell me, they're important enough for me sometimes to write down. That right there at the beginning of the fucking first session is me establishing I really want to listen to what you're saying. And me taking notes is not just, oh, I take it because I have to document it. No, I'm listening and I really want to listen to what you have to say. So, sorry for that rant. But I think, like I said, a good therapist is sometimes hard to find. Or a great therapist is hard to find. Test drive your therapist. It's okay to do that. You need to try. a couple different therapists. Try A, try B, try C. And if you're not getting that rapport, if you're not getting that connection, try a different one. A good therapist, even if they're good and you don't have that rapport or connection with them, they're not going to be mad that you didn't have the rapport or connection with them. That's fine. It's just making sure they're going to want you to pick someone that you trust and that you like. So, Melanie says we are Ken's therapist. A little bit. Honestly, I love doing what I do on YouTube and as my therapy anyway. But part of YouTube is me expressing my job and, giving you guys some insight into what it's like for at least me to do therapy, the way I do therapy, because my therapy is different. I don't know if it's the right way. Is a broad thing. It's like a general thing. I know it's right for what I'm doing. I know it works for me. And how does that make you fucking shut up? Yeah, how does that make you feel? Truthfully, I mean, it makes me feel like when I wake up and I go to work, I know I'm making a difference. I know for a fact I've saved 2 lives in important ways. One guaranteed safe, and the second turning around from drug use. For a fact those 2 I did something. The other ones I have other things I've done for. I've done improvements with, I've made progress with. Those are 2 I've seen absolutely, and I've gotten the feedback from them. I know I've done other things in other people's lives, but those are 2 that make me, want to get up, because those are the 2 I can remind myself and go, if I'm having a day where I go, I'm not really good at this, I can go, no, these are days where I actually did something really important. That lets me know that the things I'm doing are okay. Things I'm doing work. Because there's 1,000 different ways to deal with certain things. Some of them may work, some of them may not. But you gotta try the ones that. So also, Melanie needs to validate my parking. Thank you, Melanie, for validating my parking. So I'm gonna go ahead and call it. We're at basically 3 hours now. Unless there's any last questions, we covered a fun couple interesting topics. We covered the new gender, the World Professional Association for Transgender Health, new standards of care version 8, with all the issues I have with it. We covered that, some of my takes on that, and we also went into probably the fucking worst and not the most horrific, but probably the funniest licensing board report I've ever seen. So, thank you everybody for watching. Thank you everybody for hanging out. I know today was a bit more boring. I have not forgotten the drinks I owe everybody. I'm going to make those up on a separate stream. I wanted to be sober for this one so I could make sure I'm thinking it through properly. But with that, thank you everybody for watching. Make sure you hit subscribe if you're not subscribed. And if you like what you see here, if you want to support me, you can always do super chats. There's Stream Elements chats with, you can go to supportken.com/chip for that. If you want to support me on Locals, you can get access to Locals content. Supportken.com takes you straight to my Locals page, or Ken's Counseling, couch.locals.com. That's all I got for today. Take care, everybody. Stay safe and enjoy the rest of your Sunday evening. Peace. Where's my outro button? Where'd it go? Where'd it go? Where'd it go? Wait, not that one. That one.
Break it, fix it, crash it, change it, melt, upgrade it, chart it, point it, zoom it, press it, snap it, work it, quick erase it, write it, get it, text it, save it.